Okay, so good evening, everyone. On the behalf of organizing committee, it gives me an immense pleasure to welcome you all to the fourth National Symposia on Imaging and Physiology in Coronary Intervention 2021. Ever since its beginning in 2018, IPCI has been phenomenally successful in carving out a niche for a dedicated platform to address the academic requirement related to a specific area of imaging and physiology in the field of intervention cardiology. I extend an open-hearted thank to all the founding members and the course director of this remarkable for their remarkable support and guidance to make IPCI 2021 a successful program for the fraternity in such a short span of time. I'm thankful to the organizing committee for bestowing me with the opportunity to host the fourth Symposia IPCI 2021, which like preceding year is going to be virtual edition only due to ongoing COVID-19 pandemic. As a course co-director and the organizing secretary, it shall be my endeavor to keep the content of this educational conference as interesting and scientific as possible. On the opening day of IPCA, without taking much time, I would request you all to join the IPCA 2021 for the exchange of knowledge and experience across the continent. Thank you very much. Dr. Ajit sir, please.
Yeah, thank you, Rajesh, for introducing the meeting, and it's of immense importance that we continue this program, which has been hugely successful in the imaging area, in its positive spirit of teaching and training. And I'm sure that this program, like last few years of programs, will be immensely educative to everybody, including the faculty and the course director. So without much ado, I think maybe I'll ask Vijay Kumar, who's also one of the course directors, to speak a few words before we go on to the program.
Dr. Vijay, please.
Thank you, sir. And it is extremely happy to be back again with IPCA meeting. And as with the previous meeting, this meeting also will create a lot of interest and a lot of learning will happen during the next 3 days. I invite you everyone to just be part of it and make this meeting as a great success. Thank you.
So, for the first session, which is supposed to be on acute coronary syndrome, let me invite the chairperson, Dr. Subhash Chandra, Dr. V.K. Bahel, Dr. Claire is already there with us, Dr. H.K. Bali, Dr. Rishi Sethi, and Dr. Ano Bansal. May I also request the panelists, Dr. Nagendra Chauhan, Dr. Parag Barwar, Dr. Preeti Sharma, Dr. Anand Rao, and Dr. Aftab Khan. So without wasting any time, let me start with the first presentation, first talk with Dr. Viveka Kumar on evidence-based approach for the acute coronary syndrome. Dr. Viveka, please.
Yes, so good evening, friends. First of all, let me thank the organizers for inviting me. So as you would know, the role of, can you see the slides?
Yes, we can very well see it.
So evidence-based approach to ACS with the OCT is, we are doing more and more cases with the imaging, and there is enough data to suggest that be it non-QMI with ACS with drop positive or ST elevation MI, the culprit lesion assessment is very, very important with imaging. So if you see how does it help, there is data to show, and we'll show some cases also, that it identifies the vulnerable plaque, defines the pathophysiology of the acute coronary syndrome, as you can see here, and also developing new paradigm shift in the management also. And we know that the thin cap fibroathyroma is the most of the time the most vulnerable thing, precipitating the acute coronary syndrome, and high proportion of lipid-rich core infiltration of the macrophages, neorevascularization, and cholesterol crystals are the hallmark of this. So thin fibrous cap atheroma overlying a calcific plaque. Here you can see the same thing, and that can make a plaque stable into unstable. OCT is highly sensitive in visualization of macrophages visible as single, signal-rich bright spot, as you could see here, distinct confluent in visibility at the background. There is high correlation between OCT and histological measurements and macrophages density. So the culprit lesion on OCT we can see in the form of plaque rupture, as you could see here, plaque erosion, calcified nodules would be here, which is sometimes could be mistaken. And if you see the calcified lesion of 126 lesions in patients with acute coronary syndrome, there is a clear data which shows that the plaque rupture could be seen in almost 44% of the patients, and OCT erosion in almost 31% of them, and definite and probable is almost 18 to 13%. And similar thing was studied in erosion study also. Almost patients, nearly 400 plus patients were evaluated. Plaque rupture 256 patients, plaque erosion in 103 patients, and other things like we can easily know with this imaging tool that whether there is a dissection, coronary artery spasm, thrombus, or severe stenosis, and also the spontaneous dissections can also be seen. So the conclusion of this study was that the plaque erosion is the cause of ACS in 25% of the patients, and antithrombotic therapy without stenting resulted in. So we can clearly treat the patient on antithrombotic alone and wait, and then that leads to reduction in thrombus volume on follow-up, increase in the flow area, and re-occlusion at the target site is the something which can be treated. And we also see the white thrombus and the red thrombus with that, and we know that the red thrombus has got increased MACE rate, death, MI, revascularization, and the severe also. So I'll be showing a couple of cases which real life cases. This is a case where 51-year-old gentleman presented with complaint of shortness of breath, and he had some T-wave inversion and borderline ST elevation in anterior leads blood pressure. So for 4 days he kept on having shortness of breath, and he was not comfortable at all. And at some place the angiogram was done, and we had 4 days back he was put on injection of antithrombotic, the GP2B inhibitors and all, but he did not get any benefit from that. So then again, the angiogram, repeat angiogram was done after 4 days, and his drops were high, almost 32 drop I was there. So this is the angiogram which showed. So we did a imaging of this lesion, and this is the OCT which showed that there was significant amount of thrombus. The thin cap fibroatheroma was there, and so definitely he was having significant plaque erosion and also the thrombotic flow limiting disease also. So in this the 4 days of antithrombotic therapy and GP2B inhibitor therapy did not work out. So then we thought that we should be stenting so that we can seal the flap and also restore the normal blood flow. So after the angioplasty, we did again a pullback OCT imaging, and with this imaging we could clearly see that the apposition of the stent was good. There was well apposed and expanded stent, and the MLA was also satisfactory. So you can see this is the run of the same thing. So this was very interesting case that we wanted to be treated with the antithrombotic therapy alone, but it did not work. So sometimes it can also happen that you need to you'll be forced to use these stents. This is another patient who was 62-year-old gentleman who had presented with chest pain for 1 month, blood pressure, and he was hypertensive. So this is the lesion who had LAD and the circumflex both were critical. So this was the causing the acute coronary syndrome, and you can clearly see the blood flow was also very sluggish beyond the lesion. So right artery had moderate disease. So this patient again was treated with, because the imaging catheter OCT was not going in, so we had to pre-dilate, and after pre-dilatation we did the imaging there, and post imaging this is the imaging run, and which clearly sees the significant narrowing with some amount of eccentric calcification, and then there is a, post dilatation, there is a balloon induced some, dissection as well. So post imaging, we could see that the patient had the, plaque rupture here. You can see that it was mixed kind of lesion, calcium with fibrosis was there, and the MLA was, quite narrowed down in the lesion, but in the normal segment, it was really a big artery. So we did a post after the dilating the lesion completely, stenting was done, and you can see the post stenting optimization with the, and post dilatation of the stent was done, and then the circumflex lesion, which was again significant, but did not look to be the culprit lesion in this go, but we thought we'll treat it in the same go. So then post treatment, the LAD lesion was again, studied OCT imaging, and that again showed that the full expansion is there. So at the end of the procedure, it's very important that we know that there is no distal dissection or anything which is left in out there, so that we don't have to come back to treat the lesion again. So this was the final shot in this. So if we conclude to take home message, I would say, friends, that evidence and experience have shown that OCT adds value in the management of acute coronary syndrome, and different etiologies of acute coronary syndrome can be clearly deciphered with the OCT, like plaque erosion, plaque rupture, and other uncommon things like spontaneous dissection, etc. And post-acute coronary syndrome, in intervention PCI, OCT adds value to PCI optimization as well, so that we know that the future events can be minimized in that. And there are data which shows that if you do with the imaging, you can cover the whole plaque burden, so that the repeat event and the recurrence events are significantly lesser. So I think it adds a lot of value in acute coronary syndrome settings. So thank you very much for your kind attention. And if there is any question, I'll be more than happy to answer. Over to the chairperson.
Dr. Viveka.
Yeah.
Am I audible?
Yeah, I can hear you very loud and clear.
Well, the presentations are good, but let me ask you that in your both cases, the first case, let's talk about the first case. In LAO caudal view, it was very clear that this patient has a lesion, and the RAO view also showed that there is a thrombus. So both the things were clear on angiogram. So, and I think the strategy was also clear on the angiogram that you need to stent this patient, because it was not a vessel, but there was only thrombus, there was a lesion also. LAO view was clear to show that there was significant atherosclerotic plaque in that patient. So anyway, we had to do angioplasty with some kind of, either you use RioPro or whatever you want to use it. So how really the OCT help you in deciding to different line of strategy versus if you had not done it this? Of course, I think OCT or imaging does make you things a little more clear in certain patients. But in this patient, I would have gone and done the angioplasty without any OCT.
So that's what I told you in the history also, that this patient was evaluated 4 days back. His angiogram was done, and it was felt by the operator that only anticoagulation and RioPro infusion for 24 hours should be the trick, because it was only visible in LAO caudal view, and the thrombus which showed in RAO cranial view, that looked like only thrombus and no significant
right. So the
minor plaquing.
The previous operator had not taken LAO caudal view. Am I right?
So we did not have the access to the previous angiogram, but it was the discharge summary, and then the patient continued to be in discomfort all the time, though the ejection fraction was showing mild hypokinesia of the LA territory, and the ejection fraction was also 50%, but he had clear, and the drop I had gone up to 32, so that was also quite significant.
So I think ACS was very clear. That is very clear situation. It was a ACS, and maybe that the previous operator didn't take that view. So anyway, and what about the second case? How the OCT help you to do the case better?
Yeah, so the OCT in these kind of cases, which are long, which have got mixed plaque, there is a study from Europe which has shown that with the OCT guided or image guided, if you cover the whole long plaque, the risk of restenosis and recurrence is significantly lesser, almost 23% lesser than, without OCT guided in that study, though it's significantly, it was not a, we don't see very often in that study, but definitely with the OCT guided, you cover the whole plaque segment adjacent to the significant lesion, then the risk of edge, restenosis and all those things will be significantly lesser.
So,
And also the
according to
MLA
the-
and all, and post
right.
this thing also the optimization.
According to the latest AHA ACC recommendations, what is the recommendation of OCT in acute coronary syndrome? Can you please enlighten me?
So it's still to A, so it's not something which is mandatory.
Very good. Thank you.
So, Dr. Claire, may I request you to ask the second issue? Dr. Kalra got stuck up in one of the case over there. So, you may please ask Dr. Sahu to present his presentation on imaging for assessment of no reflow.
Okay. Dr. Sahu can start his case. Yeah.
So, Dr. Sahu is the Director Intervention Cardiology, Apollo Hospital, Bhubaneswar. Dr. Sahu, please.
I think Dr. Kalra is already joined there.
Is it?
On the chat box is written, I'm here, he has written.
Yeah, anyway, whosoever is ready with the slides, I think he can go ahead. Doesn't matter.
Dr. Kalra is here.
Dr. Kalra, are you online?
Sir, no, sir. No, sir. Dr. Sahu, please carry on. I'll just talk
Dr.
to
Sahu,
Dr.
please.
Kalra and take him next, sir.
Please.
Are these slides visible?
No, sir,
Yes,
you're
it's
on the
visible.
sorter
Thank you.
view, sir. We are getting a
yes.
sorter view. Can you
That's
go to the
all right.
PowerPoint, please?
I've gone to the PowerPoint.
No, sir. Here we are getting only a sorter view. Your entire desktop we are getting. Sir,
Okay, I'll have to,
just
I'll do
stop
a new
sharing
share.
once. Yes, sir. Can you go to the slideshow, please?
Yes,
Perfect.
I want it. You get it? All right. Thank you
Perfect.
very much. I thank the organizers for inviting me to talk on a very unusual topic, that is imaging for assessment of no reflow. Now, what is no reflow? No reflow occurs when there is inadequate myocardial perfusion through a given segment of the coronary circulation without any angiographic evidence of any mechanical obstruction. And the question comes, why should we go for this thing that is intravascular imaging in these conditions? And we know that more than 30% of the patients post thrombolysis or post PCI have a no reflow phenomena. This is what is the no reflow phenomena, in which you can see the artery is not fully filled up by the contrast. And if you try to see, there has been a TME grading from 0 to 3. 0 is when there is a complete occlusion, and TME 1, there is a partial penetration with no distal perfusion. TME 2, where there is the entire artery is perfused, but there is a delayed flow, and TME 3, where there is a full perfusion normal flow. Then came the TMP studies, which all showed that higher is the TMP grade or higher is the TME grade, the results were bad. Now, coming to what are the causes of no flow, they're basically distal embolization, ischemic injury, and the individual susceptibility has been also seen, and reperfusion injury. Now, this slow flow or no flow can occur within seconds to minutes, possibly after an interventional procedure when there is some microembolization and the secondary ischemia, or they can occur within hours when there is ischemia-induced injury, myocardial edema, endothelial swellings, vasospasm, inflammatory response, or distal coronary embolization. Post-acute MI, it occurs due to the various reasons which I have already highlighted, and post-elective stenting, we also see that immediately after stenting, we can get a no reflow. Basically, these are due to distal coronary embolization, which is very common, or any secondary inflammation, or in a spasm, cell death, or microvascular obstruction. Now, the question comes that is intravascular imaging required in no flow situations? This is something which one has to answer, because no one would like to put a catheter inside the coronary when there is no flow. One has to be very careful, because we know that putting a catheter has got its potential harms. Firstly, you might embolize the thrombus much further, and this might lead to more problems. You might enter a false lumen and cause further dissection if you're not in the true lumen, if there is, you're not sure about where you're going because the whole channel is not visualized. The OCT contrast injection may be potentially risky, because when you inject with pressure, you may cause more harm than good to the patient. And sometimes when you take a pullback with an IVC or IVUS or OCT, you may drag the thrombus to the ostium and you may release the thrombus, and this may cause further problems of even CVA or other problems. So you have to carry careful, and most importantly, catheters may be thrombogenic. If you're using a used catheter or a re-sterilized catheter, you have to know that you have to maintain the ECT at least more than 300 while going for this. So these points should be very clear when you're trying to do an OCT or an IVUS in a patient with a slow flow or a no flow. Now, I shared some cases where this is helpful. For example, as Dr. Viveka had shown whether to use both for pharmacotherapy or stent in a case in which there was a slow flow, you can see there was a big chunk of thrombus sitting. And moreover, this is just an erosion that has taken place. Here, there's no need to put a stent. Just do a thrombosuction and give intracoronary GP2B3A, and you'll see on table only. You can do, if you take a second run, you can see that the results are good. So this is one of the potential uses of in our native case, in which it has just shown either no flow or a slow flow. You can go ahead. Immediate post-stenting, you can get a no flow. For example, you see that the left system was normal. And when you move to the right system, you can see there is no flow at all. I can see some amount of thrombus here. So the plan was just to pass the wire. And when the wire was passed, you can see that the thrombus went down. And of course, there is a good TIMI3 flow over here. So this is just the OCT to show that there was still a lot of thrombus. And if I try to analyze the OCT findings, you'll see that there was a chunk of thrombus, and the catheter just went down, making some space for the contrast to go. And then what we did was just to put a stent over here directly, and the results was good. So this is post-stenting results, which showed very good. But immediately after the catheter, this is post-stenting results, which shows that we have done a good job. This stent has been well opposed. But what happened immediately after we sucked out the catheter was that suddenly the whole artery got closed. So this is something very alarming. And these are certain situations where you know that your wire is in the lumen, and possibly you have to take an OCT catheter to know what's going on, or else you just have to go and take a stent and put it across. When we took a catheter, OCT catheter, and tried to see, again, when the wire crossed inside, we could see that there was an ostial dissection over here. And now when we did the OCT of this case, we could see a large dissection which had taken place. So this dissection, the flap had fallen down. Luckily, we were in the true lumen. Of course, the wire was in the true lumen, and this flap had to be dealt. And so the most possible thing that could be done was to take another stent and go ahead and stent it straight forward. So these are certain insights that we get in no flow, when especially post-stenting. And this is just to show you the result, what happened, the final run. This is after the second stent has been put. There was still some area of Malapo stent where a pot needed to be done. So you can just see that this is the first stent, this is the second stent, and the pot was required for a good final result. And this was what happened after putting the two stents. We could see that results were good. Now, sometimes this slow flow or no flow comes in a delayed presentation. For example, this was the case which was done in another center, which in fact was a good result. And this patient was discharged, but was readmitted to my center after 35 days of a primary PCI done in the initial center, and came again with the re-MI in the inferior wall. So the next thing that was supposed to be done when this was an anomalous RCA, and we could see that the stent had thrombosed. So now the cause of thrombosis can be known if we can just try to find out, put to an intravascular imaging. In fact, we went for this thing, thrombosuction in this case. And then after that, just took down an intravascular ultrasound catheter and did a little bit of post-dilation. And what we could see was there was some amount of intimal hyperplasia, there was ring calcium, and the stent was not opposed. So that was the reason why this stent had thrombosed. So the next point was to just dilate the stent and just oppose it properly, because the procedure had been just done around a month back. And that is what we did. We just optimally opposed the stent, and finally we got a good result. In fact, giving a little bit of GP2B3 in intracoronary, we could see it. So this is another issue where you have a stent thrombosis where there's no flow. Possibly your intravascular imaging will definitely help you know what is the cause of the stent thrombosis and help you. Dissections do lead to no flow, and we know that it all depends on what is the type of dissection. If it is a retrograde dissection, we're not worried because the flow is downwards. But if it is an antegrade dissection, the flap might go on increasing and we may be in problem. For example, if OCT clearly helps you which dissections are to be tackled, which dissections are not to be tackled. For example, if a dissection is intimal or media, if it is less than 60 degrees, if it's less than 2 millimeter length, and if the residual lumen narrowing is more than 4 millimeter, there's no need to stent. You can defer stenting. So this is a case in which you can see where proximal dissection has taken place to the tune of the angle being almost 120 degrees. And as we come up, we see that there is a dissection continuing up to 90 degrees. And still here also the dissection 60 degrees. So there was a long dissection and the length of the dissection was approximately more than 3 millimeter. So this is what you see, that it was a very large dissection and there was this almost a no flow phenomenon which had taken place and the dissection had to be tackled. And here we had to put this proximal, this was a proximal this thing antegrade dissection, so a second stent had to be taken and the results had to be done, had to be given. And this is how you can know that definitely on the final OCT analysis, you can see that the stent was very well opposed and it was seen that the second stent is overlapping the first stent, and you could never have left this dissection alone because this was in the ostial part of the LAD. Now, finally, if I have to summarize, how does imaging help in no flow? No flow in ACS, if you have a high thrombus burden, it helps you know what is the type of thrombus and what is the strategy to be done. Number two, the plaque morphology can be evaluated. You can know whether there is how much calcium is there, whether you have to prepare the plaque properly. Next, is there any mechanical obstruction? But by definition, no reflow means there should not be any mechanical obstruction. But this mechanical obstruction can occur post PCIs, where you have to be careful and you have to know what is the cause of mechanical obstruction and if at all this mechanical obstruction needs any treatment or not. Decision regarding just giving pharmacotherapy or doing a mechanical intervention can be done in no free flow, but definitely you have to be very cautious to maintain your ACT levels or else you will land up in problem. Finally, post-stenting dissections can be known, incomplete apposition can be known, inadequate expansion of stent can be studied. So all these are advantages of doing imaging in no free flow phenomena, but we all as interventional cardiologists should remember one thing, that first do no harm. Because there are many times where we have seen that you push in a catheter, you cross further no flow and problems do start. So that is what the message should go loud and clear. Thank you very much for the patience.
I think this was a good cases, and I certainly agree with Dr. Sahu that in no flow or slow flow, I think a quick IVUS run can be very useful. Imaging is useful because if there's no dissection, there is only no flow or slow flow because of distal embolization, then at least you know that you don't have to stent it. And if you find that there is significant stenting proximal to the stent or distal to stent, just go ahead and stent it, then you may be able to cure that no flow or slow phenomena. I think anybody else is welcome to give the comment, but I think it's definitely one good indication of imaging when you have slow flow or no flow phenomena.
With the due permission of the chairperson, let me invite the next presenter, Dr. Kalra. Dr. Kalra is Assistant Professor in the Department of Medicine at University of Toronto and intervention cardiologist and cardiac critical care physician at Peter Monk Cardiac Center, Toronto General Hospital. He has the expertise in complex, high-risk and chronic total occlusion angioplasty, mechanical circulatory support, and cardiac critical care. So Dr. Kalra is going to talk about IVUS guided zero or ultra low contrast PCI. Dr. Kalra, please.
So, one second, your audio is still not on.
Is this better?
Yes, sir.
Great. Thank you very much for the gracious invitation to speak this morning. The topic that I was assigned was the uses for IVUS and ultrasound low contrast PCI. I'd be happy to share any tips on a step-by-step approach to perform this procedure. That's not where I focused our talk today. I did focus it on the use of intravascular imaging and how you can use it as part of this procedure. We will certainly go through a case though. These are my disclosures. So we'll start with this case of a 71-year-old man that was admitted with an acute coronary syndrome. He has the usual cardiac risk factors, and he was further complicated by liver cirrhosis. So he had an INR of 2.5 and platelets of 60,000, acute kidney injury with a baseline creatinine of 2.7, and severe peripheral vascular disease. And unfortunately, despite our very best efforts, we were unable to get him stabilized on medical therapy where we could even get him angina free to allow his various metabolic parameters to improve. As a result, we were pressed to intervene on this gentleman while his creatinine was high, recognizing that the optimal scenario would be to treat his INR, make sure that it's stable, and to try to get his INR, try to get his creatinine back down to its baseline before bringing him to PCI, whether it's zero or ultra low contrast or typical, because one always wants to have some degree of safety. This was his pre-op echocardiograms. You can see that he's got a fairly marked segmental wall motion abnormality here in the anterior septal and lateral walls with predominant contraction in the inferior walls and an overall poor EF. So these were his diagnostic angiograms. They were ultra low contrast, sort of 2 cc's a piece. That's the proximal RCA. And then this is the angiogram that we performed at the beginning of our case in 3 cc's in the apicaudal view of the left system. We were given angiograms from the previous site, but unfortunately they weren't very useful because most of the vessels were overlapped. And that's a lesson about zero contrast PCI, which is that you've got to pick single views that will expose exactly where the vessels are that need to be treated. So in this case, this was a calcific distal left main into a ramus and then into a tiny chronically occluded circumflex. When decision-making regarding this case, we decided to treat the proximal vasculature in the large ramus and LAD and leave the circumflex for later. This is just a tip on injections, short, quick injections, 4 cc's maximum at 25% dilution, and make sure that you don't waste any contrast in the guide. So we all know the purpose of zero contrast PCI. What we recognize, though, is what it is not. This is not PCI blind. This is just PCI seen differently, hence the use of intravascular ultrasound. The idea is to be able to recreate the things that you would typically identify on an angiogram using an intravascular imaging tool rather than seeing using contrast from the outside. So there are 6 main uses of this device within zero contrast. Number 1 is assessment of the peripheral vasculature for large bore access. So in this gentleman, we decided to place a hemodynamic support device because of the severity of his LV dysfunction and the extensive revascularization that we were going to perform that included calcium modification. The way you do this is by doing your micropuncture access and placing an 018 wire, so a supportive 018 wire through your micropuncture sheath in your peripheral vasculature, okay? A V18 wire is optimal. Then you place either a peripheral IVUS or failing that, coronary IVUS, which obviously would have to go along an 014 wire with the field of view maximized, and you place it in the peripheral vasculature and you pull back. Make sure that your wire is far down the vessel that you're assessing so that you have some room to pull back and pull the IVUS all the way out the arteriotomy if you have to. Then you put pressure on your arteriotomy because at this point it's still quite small. Put your micropuncture sheath back in, exchange for the type of wire that you would use to put in your access. If you're happy with your peripheral vasculature, which here you can see has no disease, right? So you're happy putting in large bore access, and then proceed with your access and device implantation. So in this case, we ended up putting in an axillary impella CP along this supercore wire, which we put in through the micropuncture sheath after confirming the appropriateness of the access using this IVUS technique, coming right back to the point of entry into the vessel. And this is the impella going in from the left axillary along the impella wire. Okay, and this is a case that we happen to use hemodynamic support, and it's not to suggest that all of these cases have to be done with hemodynamic support. The next thing is to define your proximal and distal landing zones using fluoroscopic guidance. So what you want to do after you've prepared your vessel is do your IVUS and then identify your landing zone. So what you're looking for is a place with less than 30% plaque and not a ton of calcification. So advance the IVUS on real-time visualization until you find that point, right? So this was the best part that we could find for visualization in this gentleman. And then you fluoroscopically co-register it by cineing where the lens is. That's how you know where it is. And the first thing that you do so that you have some fluoroscopic markers is make a wire skeleton of the heart. So put wires into every major vessel that you have so you can create a wire skeleton that matches your angiogram. That way you don't have to puff, puff, puff. You identify your distal landing zone by finding the place where the IVUS lens is, where the vessel is appropriate for stenting, and then cine that. So you have it marked in a fluoroscopic image. Then you do your IVUS, and as your IVUS comes back, you start to identify the nature of the plaque, the length of the lesion, and the proximal landing zone that you want to use. So this was our proximal landing zone. This was back into the left main for this gentleman. And so we decided to come all the way back to the ostium in his case, because he's got a fair amount of plaque here. And so that's how this is how we did that. This is your fluoroscopic distal marker. And then this is your fluoroscopic proximal marker, which was roughly here in the left main. Okay. And then we chose to bring this back to the ostium just because it was only a few extra millimeters. So you could argue that you could just land the stent here. So distal landing zone, proximal landing zone. Okay. And then once you've identified your proximal and distal landing zones, what you want to do is be able to measure the size of these landing zones. Recognize that the more stable your guide is, the faster the pullback, the less back and forth movement of the guide catheter. And so the more accurate your length measurements will be. So this is the distal, we measure the distal, understand exactly how wide the vessel is from EEL to EEL. In this case, because there's plaque, you would stent lumen to lumen and then expand using a post-dilatation balloon sparing the last strut. You do the same thing for the proximal landing zone. This is from a slightly different case, but these are example pictures. And then you also nail down the length of your lesion. And this is using the longitudinal view on the IVUS. And that's where the discussion that we had comes in, where as long as your guide is stable, your heart's beating will not appreciably change the length of your IVUS. If your guide is outside the vessel, your guide will be going back and forth, and so will your IVUS lunge, and that will artificially lengthen your measurement. Then you define the plaque composition to facilitate vessel preparation. So we recognized proximally that this was a heavily calcified lesion. We knew that we would have to prepare it appropriately, and so we used a Wolverine cutting balloon to really fully pop this open. We saw that there was already a fissure here and that this was just under 270 degrees of calcium. So we're right at about 270 degrees of calcium. So we were quite comfortable trying to use a cutting balloon. And then actually IVUSed again to make sure that we could see cracks in the calcium that made it an appropriate place to be able to stent. The next thing was we stented. And then of course you want to stent optimize, right? You want to make sure that your stent optimization result will give you a distal, and there are no perfect agreements on this. It depends on which trial criteria you use. But then on the IVUS, you can define whether or not your stent is optimally expanded by using a greater than 90% minimal stent area in comparison to your distal minimal lumen area. That's the criterion I use. Some people use 80%. The other option is to use FFR or IFR to check the flow in all directions to ensure that you have physiologically normalized flow after stenting. And so this is an example of that, where we've just IVUSed back all the way into the left main to prove that our stent result is indeed optimized after post-dilatation. Then, if you want to do bifurcation stenting with this is a slightly different case. And if you're going to try to nail the ostium of a bifurcation, what you can do up front is select an 8 French guide, because that's what you need. You select a 5 French compatible IVUS, and you place the IVUS along a second wire in your target vessel. So this IVUS is, let's say, inside a ramus branch. And what you're trying to do is nail the ostium of the ramus branch. What you do is on a wire next to the wire on which the IVUS is sitting, you place your stent. And then you pull your IVUS back until you identify the precise ostium of the vessel on the IVUS. And then you pull your stent back until the proximal position of the stent matches the location of the lens. So you know that the proximal stent position, which is here, is lined up at precisely the ostium. Then you carefully pull back the IVUS, making sure that the stent doesn't dive in, and you deploy your stent. And this is what you end up getting. When you do that on real-time visualization, you see that the stent gets deployed on the IVUS. Okay, it's just very important to make sure that your IVUS is fully pulled back from the ostium of the vessel when you do that. Okay, so this is your stent being deployed, and that's your balloon coming down. That's what it looks like at the very end. Okay, you need an 8 French guide to do this because a 7 French won't give you enough room. Okay, so in this case, we did the ramus, then we did subsequently in the LED back to the left main. These are the final stent results in this vessel. As you can see, we did truly nail the ostium of the ramus, which is right here, using that bifurcation approach. And these were our final results. 3 cc's of contrast here, and 3 cc's of contrast here. I'll stop at this stage given the time, and thank you for your time and attention. Unless we have an extra minute or two, then I can show you it.
Dr. Kalra, how frequently do you use microcatheter to have a low contrast during the intervention?
Could you repeat your question once, please? I'm sorry.
How frequently do you use microcatheter to inject the contrast during the PCI?
Never.
Okay.
Never. There's in general, I mean, for those of us who do CTO PCI in general, distal tip injections with microcatheters have one purpose, and that's to define collaterals. Otherwise, either way, your case is done. Either you inject into the subintimal space or you're in the true lumen and your case is done, you know it. So in zero contrast PCI, ultimately the use of a microcatheter is just if you need to really swap out wires or if you need to facilitate your wiring. But when you're doing zero contrast or ultra low contrast, that's exactly what it means. You're not really taking puffs because you're not using contrast to define your positions. You're using intravascular imaging. That's the purpose of the technique.
Dr. Bali, for any comment, please?
I think a wonderful presentation by Sanjo. My only concern is the case which you mentioned about bifurcation stenting and nailing the ostium. In a patient who has calcified artery and we are trying to nail the ostium, we would have some issues with an IVUS, but I don't have too much experience of doing a bifurcation only under IVUS. But I would like to know that how accurate is it to nail the ostium with the help of IVUS?
Thanks for that question. So to be honest, that's an advanced technique. It's not something that I would recommend doing until you're very comfortable doing IVUS guided zero contrast PCI, because it's obviously there's risks to it, right? That in the hands of an operator who hasn't done that frequently, you might get into, right? The tip of the nose cone of the IVUS gets caught behind the stent, for example. The stent dives in when you're stenting, for example. So these are various things that will help you identify whether or not there are experiential things that will help you identify whether or not you're there. But every time I use that technique, I don't have problems. Typically at LED D1 bifurcations, when you have Medina 111s or even Medina 011s, I just do a DK crush. It makes it even easier. But when you're at a trifurcation like this, the challenge is that you don't necessarily want to cross back into the left main, particularly in this guy's case, in case we ended up coming back for the circumflex down the line. I really didn't want to encumber the crossing over the circumflex, and that's why this is one of the techniques that we use. But if you'll permit me an extra moment, I'll reshare my slides for a quick second, and I'll show you at the very end. The most useful application of that technique is actually when you're stenting the ostium of a left main, which is really straightforward using the same technique, right? So this is a wire down from a left main into an LAD in a different case, okay? You put the IVUS in place. Then step 2 is you can see the stent coming here, you place the stent into the vessel the same way that we had described. The next thing is you pull the IVUS back, which is here, to show you precisely where your ostium is, okay? Right, so you pull the IVUS back to define this precise area as your left main ostium, right? You'll see that the IVUS comes back. And then you sit the IVUS right at the ostium, right? So here, now it's sitting at the ostium, right? And you know where the lens is. Then you pull the stent back, okay? Or you place the stent and then you pull the stent back to match the precise location of the IVUS lens, which is right at the ostium of the vessel. And you pull the guide catheter back so you have some room, okay? Then you pull your IVUS back completely, okay? So you can see that this is the tip of the stent matching the lens of the IVUS. You then pull the IVUS back completely after confirming that you can see your stent here on the IVUS. Okay, this is just at the ostium of the left main. And then once the IVUS is all the way out, you simply deploy your stent. Okay, so this is a separate case. You're asking how often do I do this and how accurate is it? This is a different case. This is one of many cases like this. And you post-dilate, and then of course, here's your final result, right? Where if we bring this back, you'll see the stent is well optimized, and here's where it terminates, right there.
Dr. Rajesh, I don't know how much time we have to discuss, but I just want to ask Dr. Kalra, when we're talking about ostium, it's a three-dimensional. We have to see the ostium in a three-dimensional picture. And IVUS would give you a two-dimensional picture. That is one area. And second thing is that we are talking about nailing the ostium. And what are the long-term results of nailing an ostium where we have a calcified lesion, which may be actually extending into the left main, distal left main as well. I'm not talking of ostial left main. I'm talking of a left main bifurcation or a trifurcation region.
Yeah, again, so I think that the question of whether or not you're looking at a three-dimensional or two-dimensional image, I think is a fundamental limitation of the type of imaging that we use for doing our work. I don't agree that you can't get a three-dimensional image of the vessel on IVUS. The whole idea is to use both the cross-sectional as well as the longitudinal and wrap the longitudinal so that you understand what the three-dimensional structure is. Your comment regarding nailing ostia, I absolutely agree with. Your optimal way of doing this is by doing it as a proper two-stent strategy, right? But in this particular case, where I did not want to encumber the point of confluence as a result of the need to deliver additional gear, and given how sick this individual was, the decision that I made in this particular case was to try to nail that ostium. I think your point of calcific lesions extending back into the left main, no question, you're absolutely correct, which is why we use IVUS in the first place. You can't tell that on angiography. There's, study after study showing that you don't expose the left main very well on angiography. And so every time you do these types of cases, you really need to use the intravascular ultrasound anyway. If you've defined the vasculature in great detail using intravascular imaging, then you're going to know exactly where your lesion extends. In this case, the calcific lesion extended to the ostium of the ramus. The distal left main was going to be stented anyway from the left main into the LAD. So either way, I knew I was going to cover it, right? Which is why that was an appropriate technique for this case. But the point to be made is that if you're using IVUS in zero contrast or ultra low contrast PCI, the idea is to define proximal and distal landing zones, define the length of your lesion, define the composition of your lesion, and then for special scenarios, define the ostium of where you want to land your stent, for example, the left main ostium. And then these are the strategies that you would use to be able to deploy your stent appropriately on IVUS alone. You don't need the contrast.
So thank you, Dr. Kalra, for the precise presentation, how the low contrast IVUS has to be used for the PCI. That's again the complex one, and how you have used the IVUS live images to have a precise ostial stenting. Because of the constraint of time, let's move forward. May I invite Dr. Anand Rao for his presentation on role of FFR in acute coronary syndrome, culprit only or complete revascularization. Dr. Rao is senior intervention cardiologist at Holy Family Lilavati Hinduja Hospital, Mumbai. He has the expertise in handling the complex PCI, which include the left main and bifurcation PCI with the rotablation and imaging guidance. Dr. Anand Rao, please.
Thank you very much, the course directors, for having me over here. Dr. Vijay, I think my sound and my slides are all okay.
Both are visible.
Thank you.
Please go ahead.
So my lecture is on, mine is more of theoretical talk, FFR in ACS, culprit only versus complete revascularization. So we all know in our practice, 30 to 50% of STEMI patients have additional stenosis other than infarct-related artery. Current guidelines support only culprit vessel PCI. However, contemporary studies have suggested preventive revascularization, like in this case, when this kind of lesions are there, you probably want to do in the same sitting, or you want to do it in the later sitting. What is the current evidence says? So as you know, ACS symptoms and physiology, ACS is classified into STEMI, then there is a troponin positive end STEMI, and then it's troponin negative unstable angina. So this is where the ACS, we have to understand how feasible is FFR, is feasible to do an FFR in this kind of situation. Now, what is the FFR guidance recommended in ACS? If you look at culprit vessel, if for example, in stable CAD where the, for example, patient stress test is positive and you found a lesion 80% proximal LAD, and you can do an FFR, quantify the lesion, and then go ahead and fix the vessel. But whereas in culprit vessel in end STEMI and STEMI, the FFR is not recommended at all. Whereas in non-culprit lesion, all this preclinical subset, FFR can be used, and decision can be made accordingly, whatever the result is. So let's go to some studies right now. The Dynami 3 tri-multi study, which showed complete revascularization versus treatment of culprit lesion only in patients with elevated myocardial infarction and multivessel disease. This was an open label control trial. As you can see, 2,200 odd patients were randomized, and in that 627 patients had multivessel disease. They were randomized 313 patients to infarct-related. The other arm was 314 FFR guided complete revascularization, the same index admission. So as you can see clearly, the primary endpoint, that is composite all-cause mortality, non-fatal MI, ischemic-driven revascularization of non-IRA, clearly the curve separated right from third month onwards, and it went on up to 3 years. So it really showed that complete revascularization is much better. And once you take the ischemic-driven revascularization, that becomes a very important sort of driving force to show that complete revascularization is much better. If you look at the individual components, for example, the composite and the revascularization, as I told you, the curves separate quite significantly, giving a good long-term result for complete revascularization. However, non-fatal MI and all-cause death more or less remains the same in both the arms. This is a graphical representation. As you see, the primary endpoints were much better in complete revascularization. Even the revascularization strategy was much better over here, and other points, all the other points favored that complete revascularization is much better than doing the infarct-related artery. So the conclusion came from this trial was complete FFR guided revasc of multivessel disease in STEMI patient in the same index admission reduced the primary endpoints. 40% of repeat revascularization were urgent. However, they concluded that the reduction of the primary endpoint was driven by repeat revascularizations, not by hard endpoints. Then there's another very important trial called as Compare Acute trial. This is a randomized trial to investigate the validity of current guidelines to complete versus infarct-related revasc in the patients with STEMI with multivessel disease. 885 patients. This was a stable MVD multivessel disease and STEMI. 295 patients were randomized to do complete the revascularization, FFR guided. And then 1:2 randomization was done. And infarct-related artery only plus blinded FFR was advocated. And there was a 45-day window period to do the stage procedure. And these patients were followed up for almost 3 years. So the endpoints, the primary endpoints, what we call it as MACI, that's recurrent myocardial infarction, recurrent revascularization, and cerebrovascular events, MACI at 18 months. And the primary endpoints and the secondary endpoints were the primary endpoints at the end of 2 years and 3 years. Then the composite of all-cause death and myocardial infarction. If you can see here, MACE was included also in this, plus stent thrombosis. Important point is even the treatment aspects were considered. So if you look at the end results, there was a significant difference between FFR guided revasc, complete revasc was only infarct related, 7.8% versus 20.5%. And the MACI were much better in complete revascularization. Even the revascularization PCI was better in complete revascularization. So all these points were favoring the complete revascularization. Even the NACE was much better. If you look at the secondary endpoint, the NACE was much better, 25 versus 174. And repeated hospitalization for heart failure, unstable angina, and chest pain were much better in complete revasc versus infarct-related artery. So patient outcome from this trial suggested that FFR-guided complete revasc is safe and feasible in STEMI MVD and reduces the risk of events compared to angio-guided infarct-related artery only treatment strategy. Further, they concluded that there was a 13% lower MACI rates, which sort of resulted into 65% risk reductions for MACI at 1 year. On the other side, if there's untreated FFR positive patients for non-infarct related lesions are associated with 31% increased incidence of MACI at the end of 1 year. So if you look at the cost-wise, which also is important in our countries, but however, this was one of the key findings in the study was if the patient underwent a complete revascularization, the same admission, it came around $15,000. But if he had a repeat admission and came back to the stage procedure, so it was more. So there was a significant reduction in the cost factor also. So this is another interesting study which came in the Journal of Medicine in October 2019. 4,041 patients, and they were randomized to complete revas versus complete lesion PCR. 2,000 patients and 2,025 patients over here. So if you look at the primary four outcomes, if you add cardiovascular death plus MI, the curve separated. P values may not be significant, but the curves definitely was in favoring complete revascularization. And if you add ischemic driven revascularization, there was a significant difference, and this was followed up to 3 years or maybe more than that in this particular study. So this was the analysis which was presented in the ESC Congress. The primary efficacy endpoint, cardiovascular death myocardial infarction at 3 years occurred in 7.8% versus 10.5%. Very significant difference, and the major bleeding were more or less the same. Number-wise, it may be slightly higher over here, but the values are not significant. Contrast-induced nephropathy was 1.5 versus 0.9, not much of difference. So they concluded that among patients with STEMI and multivessel disease undergoing primary PCI, complete revascularization was superior to culprit-only revascularization. So this is the conclusion. I thank you very much for your patient hearing.
Dr. Bali, for any comment, please?
I would like to ask a very fundamental question which has been bothering me for some time. When we're talking about infarct-related angioplasty, we presume that the other lesions are stable. They are not acute coronary syndrome. We're talking about stability. How do we reconcile to an ischemia trial versus this complete vessel angioplasty and complete vessel? We have an ST segment elevation angioplasty done. We presume the other vessels are stable, and that should behave like an ischemia trial stable angioplasty. How does this, but all the trials show that complete revascularization would be better and ischemia doesn't show it? A little fundamental question, but that, unless you're presuming that the other lesions are also unstable or they are also hot. I would like Ajit to respond to that. That is what I'm looking at.
Well, I think that's a very fundamental question, that you're treating a ruptured plaque or an ACS plaque, and then you're trying to fix the non-culprit plaque, which may be a stable plaque, and how do you look at it? And that's the interesting part of these studies, that ultimately, whether you fix the ruptured plaque, which is first, that is for sure, and you take the non-ruptured plaque at the non-ACS in the next round, run it with FFR. Yes, you can see that though they're functionally, if they're not functionally significant, you don't have to do that. But if they're functionally significant, then whether you do it at before discharge or up to 45 days, which the complete showed, you had better outcomes than not doing it. That simply shows that yes, lesions which are tighter will rupture more often than lesions which are not tighter. And that's something which we know. And by doing a significant lesion with a significant functional test, it shows two things. One is that the lesion is tight, and two, that the area of myocardium is large. So I think both are important.
How do you reconcile to ischemia trial?
Well, you can't compare these two trials because one is a stable.
We have made a patient unstable into a stable patient. We presume that we have fixed up the unstable lesion, ruptured plaque, and we have converted that into a two-vessel disease stable. How do we reconcile?
The disease milieu is not only about plaque. ACS is a disease state of the whole vessel and inflammation. So I think we should look at it not as a plaque only, as a scenario of acute inflammatory state. And we see that very often with multiple plaque ruptures.
And Ajit, if I may add, this was a FFR guided therapy. So I think, first of all, it's very difficult to compare both the studies. But if
Sure.
FFR guided was positive, obviously they found it's better to fix in the same index admission rather than getting him back at a later stage.
Agree. And I think in the interest of time, we'll go to the next topic. And I think we have Atul to speak on a very interesting topic. Atul?
Let me invite Dr. Atul. He's a clinical director, Sri B.D. Mehta Mahavir Heart Institute, Surat. He has vast experience of PCI during last 30 years, and he is going to talk about role of imaging in stent deformation and stent fracture. Dr. Atul Abhyankar, please.
Thank you. My slides are visible and I am audible, I believe.
Yes.
So what I'll be talking briefly about is the role of imaging. Although today we live in the world of OCT, but I think there are various other modalities also that one has to consider. I would mention about what I'm not going to talk about much. So first thing is that the fractures are not very uncommon in the stent struts. And especially as we have ultra thin strut stents or thinner strut stents, that is why there are fractures. And these happen especially on the curved parts of the connectors. Of course, there are various anatomical factors, there are curvature related factors, the amount of pressure exerted, etc. But what is more important is that these fractures are kind of relevant in terms of when there is a DA strut fracture, there is also polymer damage. This may influence the local inflammation and restenosis and may contribute also to new atheroma. So that is why they are important. There are various definitions, but for sake of simplicity, we will sort of look at one of the ways. I mean, all of them are fairly similar, but just for sake of understanding. So type 1 is a single strut fracture or gap between the struts, which is more than twice the normal gap that is expected. And now type 2 is multiple strut fractures with a V-form division of the stent. Type 3 is a complete transverse stent fracture with a separation of the fragments by about less than a millimeter. And type 4 is where you have a complete separation and you have a displacement of more than 1 millimeter. Now, this is kind of definition. What is important is there are many times various limitations of understanding these types when you are using fluoroscopy, when you are using even stent boost. Now, this is an example of a high density fluoroscopy where you can see that there are various levels of fractures here. So this is something which by definition, because actually the strut separation is not much, we don't know whether this is a fracture. In this case, we can clearly see that both the struts are separated, but the gap is less than 1 millimeter. Here, the struts are significantly separated on the bend, and this is like a type 4. This is another type 4. I don't know whether the image is very clear, but you can see a cross separation after fracture of the stent. So one of the simplest techniques to diagnose strut fractures or stent deformation is by high density fluoroscopy or stent boost kind of technology, but it obviously has its limitation, and sometimes you can have confusion, especially when it is not type 3 or type 4. So when you're talking of the first two types, that is difficult. So how do we sometimes see on angiography, here there is some kind of restenosis. Now, if you look at this IVUS image, what you find is that the struts that we expect to be present on all sides, you can see that there are only two struts and there is an absence of strut on this, showing that there is a stent deformity or a stent fracture on one side, and that is why the struts are missing on one side. This is another case where there is a separation. This is clear even on fluoroscopy or high density fluoroscopy. But if you want to do an imaging, you want to confirm on an IVUS, which sometimes may not be very essential when it is so clear cut, but you can see that there is complete absence of struts here in that scenario, which shows that there is a separation of struts. This is an ostial RCA lesion treated where the stent boost shows you that there is a separation. So by our definition, this is like type 1 or type 2. Now, what you see, however, on the OCT image is kind of very clear-cut picture that there is a somewhat crowding of struts at places. There is a plaque and there is a complete deformation or loss of structure in this area. And you can see that the ostium, which angiographically did not look so bad, appears to be completely deformed. I mean, the stent appears to be completely deformed and grossly non-circular. So imaging when the things are not very clear, or even when you can at least understand that there is some deformation, but it can be defined much better when you are doing some kind of imaging. This is the case of a left main. Now, if you look at this angiographic picture, you find that there is a slight indentation here. And sometimes you may feel it's kind of just an under-expanded stent, and you may want to do more kind of port or higher pressure, etc. But if you do a stent boost, then it clearly raises a suspicion that there is a stent fracture, which is kind of seen in the IVUS here, that there is absence of struts. Now, in this OCT images, what you can find is that there are struts only on this side. There are no struts visible on the other side in both the images, which clearly shows that there are areas which are devoid of stent. So there is a breakage and there is a separation of struts, and there are areas which are not covered by the strut at all. So on the imaging, whether it is IVUS or OCT, the easiest way or the way to detect that there is a real genuine stent fracture is that when you have a complete absence of stent in the certain part of the circumference. Now, this is a case of acute coronary syndrome where, again, fluoroscopically in one part, you can clearly see that there is a gap. This is confirmed by OCT that there is absolutely not a single strut visible. This area is completely devoid of any stent. In this area, you can see here that part of the circumference does not have a stent. And in the next frame, you can see that there is a lot of thrombus that has been formed due to the deformed stent. And this area, you can see that is also in some parts that there is some separation of struts. This is an image where you can see that this looks like just some amount of restenosis. If you look on high density fluoroscopy, it is on outer curvature. It's very difficult to decide whether this separation is genuine, whether it is because of it is on outer curvature. But if you look at the OCT image, one, you see the tissue growth, no doubt about that. But what you see is that there are only 3 struts visible. I mean, normally the sun ray appearance that we get, so that's absent here. And there is a lot of area, almost 180 degree of circumference, which is devoid of any strut, which clearly shows that the separation that we can see on the stent boost of fluoroscopy is genuine and there is actually strut fracture. Various patterns have been described by some authors for this deformation of stent. So the pattern 1 is that there is only one stacked strut. Pattern 2 is when you have multiple stacked struts. Pattern 3 is where you have a deformation of stent of some kind, and 4 where you have a transection with or without gap. That is similar to the type 3 and 4 that we discussed earlier. Now, looking at another case, this is a patient presenting with acute anterior MI, complete occlusion of LAD. This is after passing just a wire. There is some flow has been established. And when the imaging is done, what you can see, this patient had previously 2 stents and overlapping stents. And you can see that there is a gross sort of malalignment separation of the 2 stents. The overlapping stents are completely separate from each other. There is a good amount of tissue prolapse, and the stent, you can see there's some struts inside and a gross deformation of struts and a breakage. So this is for the same patient where you can see that there is actually what you could not see on angiographically so clearly, that there is a clear breakage or separation of struts. Another stent was put and final result was achieved. This is another example of this overlapping stent and strut separation. As you can see that there you can see one circle which is very complete. But if you look at the other stent, then you can see only a few struts only on one side. This is the OCT as well as IVUS. So here you can clearly see that one circle of struts is complete, the other circle is grossly inadequate. Another case where you can see that once the artery was opened and high density, means the stent boost was done, here you can see that there is some amount of separation. You can see as this arrow shows some amount of separation here. So in these areas, what you can find is that the struts are not looking as uniform as they should have been, that there is some separation of struts circumferentially. There is almost absence of struts in this frame, almost at 180 degree, and there is some amount of crowding of struts that has happened on one side in this frame. Another example where you can see that this is the strut that is visible on fluoroscopy. You can see a doubtful or somewhat suspicious gap. This is confirmed because at this point you find that there is absolutely no strut that is visible, showing very clearly in this frame that this part of the artery does not have any stent cover. I will lastly show a very fresh case, fresh from the oven, done just yesterday late evening. This is a right coronary artery which was stented with multiple stents about 6 years back. And the patient now came with unstable angina, increasing pain. And this was the angiogram. So you can see here, now what we have learned over a period of time is that those restenosis which we used to treat earlier, which used to come in 6 months, 8 months, and we used to just balloon dilate them, put another stent if required, and the procedure used to be very simple, straightforward, did not need any additional device. We know now that these late appearing restenosis or late appearing lesions in very old stents are very different from those kind of restenosis that we used to see in the early days of drug-coated stent also. So now we know that you need an imaging. And if you saw there, what you can see here, because of the calcium and the stent struts, it is very difficult to sort of understand what exactly is the scenario with the struts, where is the calcium causing problem. But what was interesting that we found is, I will show you in the OCT run, and I will try to be as brief as possible. Okay. So I will just stick to the required frame. Now, if you look at some of these frames here, what is clear is that there are frames where you will find that there is actually no strut. So what we thought that the whole area is covered with stent, there was obviously a gap where there is a clear-cut lesion. You can see some deep-seated calcium, but otherwise it's a kind of a mixed plaque. So that is something that we understood, that there is actually no stent in that area. Probably there is a stent fracture which is separated. And now as we come back, what we will find here is also on something very interesting, is a completely deformed kind of stent which is crumpled. And you can see that the stent size looks quite small. This is some kind of recoil or deformation. You can see that the stent of size, the vessel is about 4 kind of millimeter vessel, but you can see here at this point that it is grossly distorted and sort of deformed stent. So the strategy wise, it was very clear that this stent had to be expanded properly, which was deformed. And unless we could expand this stent properly, so using of cutting balloon or a rota, because it was a large vessel, So we thought that the best option was to do high pressure balloon using an OPN, and that is what was done. And now you can see here, I'll just run through thing in this area, dilated adequately. And this is the area where the stent was grossly deformed. Now the area has increased quite significantly. The stent is kind of the previous stent, which was deformed, is fairly well expanded. And this is the last image where you can see that in this area, which was kind of not covered previously with the stent, so quite reasonably circular diameter. And this is the area where the stent was grossly deformed. Now you can see that it's a nice circular limb, pretty good area. So the deformation was visible kind of also to some extent on stent boost, but the OCT made it very clear as to the strategy was required where a high pressure balloon would have helped in extra dilating the previously deformed stent to create a proper lumen before we could put in a stent. So this is at the end of the final stent image, and this is the angiographic image. So thank you.
I think that's an interesting case. Two beautiful images. Thank you very much. And I think we are a little short of time, so we will go on to the next session. Rajesh, please go ahead and introduce.
So, thanks, Chairperson, panelists, and all the speakers. Let's go ahead for the next session. It's about a big debate regarding use of IVUS versus OCT in the clinical setting. And for this particular session, let me invite the Chairperson, Dr. Srinivas Kumar, Dr. Simon Matthew, Dr. P.K. Goyal, and Dr. Sridhar Kasturi. Let me also invite panelists Dr. Kunal Mahajan, Dr. Praful Sharma, Dr. Kuntal Bhattacharya, Dr. Jaspal Aneja, and Dr. Imraj Hafiz. For this particular session, the first talk is going to be given by Dr. Gary Means about use of IVUS. Is it scientifically backed and should be used for all the lesion? As you all know, Dr. Gary Means doesn't require any introduction. He is a pioneer in using the intravascular imaging for the coronary intervention. He is presently a senior medical advisor at the Cardiovascular Research Foundation and is the director of TCT. He has authored more than 1,000 peer-reviewed articles, 60 book chapters, 4 books, and 850 abstracts concerning various aspects of clinical cardiology, cardiac ultrasound, hemodynamics, cardiac radiology, coronary angiography, intervention cardiology, and especially intravascular ultrasound and physiology. Dr. Gary Means, please.
Thank you very much, and thank you for both the introduction and the invitation.
Our pleasure.
These are my disclosures. So personally, I find these debates of IVUS versus OCT or FFR versus non-hyperemic pressure ratios to be tedious and not very productive. To me, the real debate is imaging and physiology versus angiography alone. But my assigned topic is to show that IVUS is the gold standard. That is, it is more scientifically backed and should be used for all lesions. So let me simply ask a question. What is the definition of a gold standard when it comes to guiding stent implantation? And I would submit that the gold standard is the technique that improves patient survival and reduces mortality. As of August, these are the studies that have compared imaging versus angiography-guided DES implantation. The studies in white are IVUS, the studies in blue are OCT, and the studies in yellow contain both IVUS and OCT information. But let me show it to you a little bit differently. IVUS and OCT broken down by total studies, randomized trial publications, meta-analyses, and registries. Overwhelmingly, the amount of data and literature favors IVUS guidance. But now let's look at some individual studies. These are the major meta-analyses combining randomized trials and registries of IVUS versus angio-guided DS implantation. And if we just look at mortality, all-cause mortality, the reduction in all-cause mortality is approximately 40 to 50% in these major meta-analyses. And if we focus just on meta-analyses of randomized trials, and they mostly reported cardiovascular mortality, again, about a 50% reduction in mortality in every single meta-analysis looking at randomized trials. This is just one of them. Was published 2 years ago, and you can see that IVUS-guided PCI was associated with the lower incidence of cardiac mortality, as well as a reduction in MI, TLR, and definite probable stent thrombosis. The two largest studies, individual studies, are of course IVUS XPL and Ultimate. They each had at least 1,400 patients. But what we have done, and this is now in press, is we combine the patient level data from these two studies. And when you combine the patient level data, you see a reduction in cardiac mortality by 50% with IVUS guidance compared to angio guidance. And if you optimize the stent according to IVUS criteria, the annual mortality after DES implantation is 0.15% per year. Now let's look at some patient lesion subsets. This study from Samsung in Seoul, Korea reported all-cause mortality over a 10-year time course, and they divided it based upon patient characteristics and lesion characteristics. And you can see that irrespective of the patient characteristics and pretty much irrespective of the lesion characteristics, IVUS guidance reduced cardiac mortality across the board. So let's focus down on a few specific lesion subsets. Let's first look at left main intervention. In terms of deferring left main intervention, FFR and IVUS have about the same outcomes. And so IVUS can be used to defer left main intervention with the same data, the same mortality as using FFR. When it comes to left main stent implantation, there are only a couple of randomized trials, but there are 11 studies, and this is a meta-analysis looking at all 11 studies of IVUS versus angio-guided left main stenting, and you can see a reduction in all-cause mortality and cardiovascular mortality, as well as a reduction in stent thrombosis, MI, and TLR. To me, the most impressive study comes from the UK. This is a national registry in which IVUS guidance reduced one-year mortality by 34% and was most beneficial for the operators with the most left main PCI experience. In other words, the operators with the most left main PCI experience had the greatest impact on their mortality when using IVUS guidance to optimize the procedure. Another important patient subset are patients presenting with STEMI, and you can see that in this national online registry from Korea, a reduction in patient and device-oriented cardiac events because of a reduction in all-cause and cardiac mortality with IVUS guidance. Sanjeev Kalra gave a very nice talk on imaging-guided zero contrast PCI. This shows some of the data that he also showed, but let me point out that if a patient comes to the cath lab with chronic kidney disease and develops contrast-induced nephropathy, the one-year mortality can be as high as 25%. The best way to avoid contrast-induced nephropathy is to avoid using contrast, as was pioneered by Ziad Ali in our group. And now this is a routine part of our PCI armamentarium and involves even complex procedures with calcium modification and has been extended to treatment of vein graft disease as well. So I am often asked or often told that people understand how IVUS can reduce stent thrombosis and can reduce restenosis, but why does it impact on mortality? Well, these are the studies looking at the mortality associated with stent thrombosis and restenosis. And let me just highlight two of them. This is from Castrati's group. They reported 166 left main PCIs that presented with restenosis that were then treated, and the patients were followed for 5 years. The 5-year mortality when a patient presents with in-stent restenosis after a left main PCI is 30%, 6% per year. And this study, Impress in Your Intervention, is from the US Medicare database of over 66,000 patients. If a patient in the Medicare age presents with in-stent restenosis that is then treated and the patients are followed for 4 years, the mortality is 7% per year. So just reducing stent thrombosis and of course, stent restenosis and of course stent thrombosis will reduce your mortality. And this, to complete the picture, this is a paper from the Washington Hospital Center reporting events after IVUS-guided treatment of in-stent restenosis. And you can see at 3 years, the all-cause mortality is reduced from 16% to 11%. So in patients undergoing PCI, IVUS-guided stent implantation reduces mortality in almost every clinical scenario. I submit that nothing is more important than improving patient survival after stenting. Thank you for your attention.
Thank you, Dr. Gary, for an excellent talk. And let us have the OCT presentation by Dr. Jonathan Hill, and then we'll have a discussion. Is that okay, Rajesh?
Yes, please. So let me invite Dr. Jonathan Hill. He's a consultant intervention cardiologist, chair revascularization group at Royal Brompton Hospital, London. His special interest is there in imaging and vascular repair and healing following the coronary intervention. His main clinical interest is in the complex coronary disease and chronic total occlusion. He is a keen proponent of the concept of precision PCI and the integration of OCT in complex coronary intervention. So may I invite Dr. Jonathan Hill to go ahead with his talk on OCT, the game changer. Orange is the new gray. Dr. Hill, please.
Well, thank you very much for the invitation to participate in this meeting. So the title of my talk is Orange is the New Grey. So again, I agree with Gary Mintz that I think this debate is actually is rather tedious. I think we can't engage in the either or debate, which is better. I think we need to be focusing our efforts on more universal application of intravascular imaging, whatever the modality. My focus has been on the increasing complexity of coronary disease, and in particular looking at this sort of CHIP population, especially patients with CTOs and often patients with complex multi-vessel disease, often involving the left main stem, often involving left ventricular support. And with this increasing complexity, it is incumbent on all of us to get this every intervention as fully optimized as possible. Now, whether this is in the context of an acute coronary syndrome, here a patient with multi-vessel disease involving the left main, with bifurcation disease, bifurcation left main, you need to have the imaging data at your fingertips. If it's OCT that's giving you that information with a very high degree of fidelity, absolutely, that should be the information you should use. Of course, you can get this information from IVUS, but whatever it is, whatever the modality you choose, you should use the information to guide your intervention, with the idea that, of course, these interventions, you optimize the immediate outcome, and in so doing, you optimize your long-term outcome. So with left main intervention in particular, where I think we have been less inclined to use OCT, the data that you get from the OCT measurements, I think, are entirely comparable to the information that you get from intravascular ultrasound. And in fact, you can get some additional information that you don't get from OCT, looking at stent apposition and, in fact, the precision of stent around the bifurcation. So an OCT guided workflow and an ACS lesion with a left main bifurcation can deliver precision PCI. So there are everyday applications of OCT in both simple and complex disease. In ACS, long and multi-vessel disease, bifurcation, CTO, LV support, and calcified disease. Left main stem disease, which is calcified, which is a very common combination, you have to do again with the maximum level of precision. So this is one of the early cases with the use and with availability of intravascular lithotripsy. Now, the additional information that OCT gives you over and above the angiogram is the distribution of the calcium. And in particular, if you compare it to IVUS, it gives you a much more precise measurement of the thickness of calcium. So I think that this can be seen as potentially a game changer because it can determine the calcium modality that you use within the left main stem. And remember, we need to maximize our expansion, and we're aiming for the maximum stent area, and we're wanting to deliver that because of our long-term outcome gain. And so in this particular patient, we were able to make a very significant modification. We can see the crack within the calcium within the left main. This mechanism of action of calcium fracture is really shown only with this degree of detail by OCT. And then we can make our very precise external elastic laminar measurements. And once we have got that, the stents delivered, we've done the calcium modification, OCT, I think, comes into its own when we're looking at the precision of the apposition and the expansion, especially within the left main. And I don't think there is another modality that offers you this exquisite level of precision where we can really, in this 3D rendered view, inspect the ostium of the circumflex. We can look at the apposition within the proximal LAD, within the left main. We can even use the technology to colorize the struts. This is from the AptiView software. And we can inspect by looking around within the left main stem what our final result looks like. So OCT in this context, in comparison with IVUS, is a game changer. So what about in even more complex disease, a patient with chronic total occlusion? Well, you wouldn't traditionally think of OCT in comparison with IVUS as being the optimal modality for looking at very complex disease where there is a CTO. But this is a good example of a very complex patient with multiple CTOs, previous attempts, hemodynamically unstable. He has an impeller put in to help him through the procedure. He's got a blocked right, blocked LAD, and in fact, there's a blocked marginal there. So complex CTO anatomy, and where appropriate, if you can use OCT in this context to get the maximum level of precision, you will get the best long-term outcome. Now, the left anterior descending artery CTO was opened using antegrade wire escalation. So there isn't therefore a theoretical risk of using OCT which will propagate hydraulic dissection. The right coronary artery was opened retrogradely using dissection re-entry. So you wouldn't visualize this vessel prior to implantation of the stents, but there's no reason that once stents are implanted, they can't be optimized in a dissected vessel. But with the LAD and with the left main, there was long diffuse disease in the LAD, there was osteal LAD and left main involvement. So here, absolutely an optimized result is absolutely called for. And to ensure proper apposition and expanding, in this case, we used OCT for sizing and optimization. No concern about propagation of a dissection here because this was an antegrade wire escalation case and there was fully subintimal, no subintimal wire tracking. And in this case, we take our pre-stenting OCT measurements. We've got our external elastic lamina measurements distally and proximally. We've got the length of the lesion, and then we get our stent selection made in a very precise manner. And so in this really highly complex lesion, which you wouldn't traditionally think of as amenable to optimization using OCT, in fact, this was the ideal modality for optimizing not only this very long lesion, but also optimization of the left main. So here we have a fully OCT optimized, protected CTO PCI with left main, long LAD intervention, where the OCT in this case was, I think, a game changer in the optimization process. So I think orange is the new gray. Yes, it is an intravascular imaging modality, and I think we should be arguing about use of intravascular imaging on a more universal basis, whether that's OCT or IVUS. But I think it is a game changer, and it is a technique which I think we should all integrate within our practice. So thank you very much for your attention.
Rajesh, can I start the discussion?
Yes, please.
Yeah, thank you, Dr. Jonathan Hill, for an excellent lecture on OCT, and Gary Mitz, as usual, has covered the intravascular ultrasound. As we all understand, as you told in your introduction, each of us should become comfortable with one imaging modality at least and try to use it in appropriate patients. And as Dr. Gary always says, 80% of the times we might get away by using either of the technology, but we should become comfortable with at least one of it and start using it in our labs. But obviously the crystal clear pictures which comes with OCT are more eye-pleasing, and OCT has a very shorter learning curve, I feel. If somebody is wanting to learn new, I think he can get mastery a little more faster in OCT compared to IVUS. But now the latest HD type of IVUS also image clears our picture. Before we go on to discussions, one question I had, Dr. Gary, with this very strong data which showed volumes of patients and then 50% reduction in mortality, why do you think it is not coming to class 1 recommendation still? Like FFR is already class 1.
I mean, I have to assume that there are individuals that are so biased against imaging that they refuse to even consider it, and that they sit on the guidelines committees because it meets every single benchmark for being class 1, way, way, way beyond that, and it has for a long time. I'd like to just jump in with 2 comments, if I may. I mean, Jonathan and I agree. These techniques are underutilized and patients do better. They live longer. I mean, how can you argue against it? That's number 1. Number 2, as you pointed out, 80–85% you can use IVUS or OCT. Pick one, get good at it, and then there are specific indications for one or the other. But with the newer IVUS catheters, the measurements between IVUS and OCT are actually quite comparable. It's really the older IVUS catheters that measured too large. And the final comment is, this has to do with the previous session. I keep hearing the word apposition. The number 1 thing that drives outcomes is not apposition. The number 1 thing that drives outcomes is stent area and stent expansion. The number 2 is geographic miss. There has not been a single study that has prospectively looked at apposition and showed that there's a long-term detriment to the kind of routine malapposition that's detected. In fact, 50% of stents have some degree of malapposition when the patient leaves the cath lab. And those patients do absolutely fine. Sorry.
And malapposition up to 3 mm is acceptable. That's what is generally taken. But I think the less you have, the better it is. I think that you agree. No?
There is no data to support that. Zero data. You might as well be talking about, I don't know, anything else that you see, what the patient's blood count is. There is no data. The only thing that malapposition does that's bad is if it's at the proximal edge and you recross the stent, the wires easily get behind and you can crush the stent. But there is no prospective data in tons and tons and tons of papers showing that malapposition is bad, from, when it happens acutely in terms of long-term outcome.
What are your thoughts, Dr. Jonathan, on that? What you got to say?
Well, there's some interesting OCT data that supports exactly what Gary's saying. We looked at about just over 200 patients who were having complex CTOs done involving dissection re-entry, either retrograde or antegrade dissection re-entry. And in fact, there was IVUS guidance for the procedure and OCT for follow-up. And we had a very, very high percentage of unopposed struts in these very, diseased vessels. We had absolutely no signal at all. And I think it was a useful application of the technology, being able to measure apposition and color code the struts to 200 or 300 microns. But in fact, I think it's just eye candy in the end. I was convinced for a long time that it was important, but we just don't see a signal. And even in these very complex cases where there is apposition detected at follow-up, it's not driving clinical events. What did drive clinical events was the stent size and the outflow.
Good evening to all of you. I'm Dr. Sridhar Kasturi. My question to Dr. Jonathan Hill as well as Dr. Gary Means. So what about the registry data, sir? Because those studies are not there, but like if you see Plethysmography registry, Prestige registry, as well as Invest registry, these three major registries, always they incriminated malabsorption as one of the major predictor of the stent thrombosis. And even though the randomized data is not there, studies are not there, these registries, if you see the causes, they have put under expansion, malabsorption, evaginations, even endothelial bridges, and they also stent fractures. All these they have mentioned in the etiology list. I want your opinion over this, sir.
Sorry, I'll let Jonathan go first.
I didn't catch all of that. What you were saying? Were you talking about the Prestige study?
Yeah, Prestige and Plethysmography.
Yeah.
And even Invest registry. These are registries where they analyze the stent thrombosis very clearly, and they incriminated this as one of the major risk factors.
No.
Though many studies and randomized data is not there, but in these registries,
No. See, you're misinterpreting the studies.
Yeah.
Those are patients who presented with events. You have no idea when the malapposition occurred.
Mm.
And I would submit that most of those are late acquired malapposition because of a toxic interaction between the stent, the polymer, the drug, and the vessel wall.
Yeah. I recruited patients for that.
No, they have mentioned it as a early malapposition.
No. These were event imaging studies.
Yeah, imaging studies. Sorry.
Event at the time of the event, not at the time of PCI.
I think we are running short. Rajesh is looking. One comment I wanted to make. I wanted Ajit's opinion also in this. We are comparing IVUS and OCT. Recently in TCT also, Ajit sir compared it very clearly. OCT is clearly underestimating the vessel size. And what we performed in that also is more nearer to IVUS. So clinicians, we should be a little more comfortable and accept a quarter size bigger than what is shown. Even if they come taking EL to EL, also sometimes you are undersizing the stents. What are your comments and thoughts on this?
I agree. I think this has been discussed in many meetings. I think Gary and many of the people who are actively imaging, we know what OCT will give you in terms of numbers and what IVUS will give you in numbers. And we need to take these imaging tools together. And yes, I compared the same case in the TCT case and showed what IVUS shows and what OCT shows. But I think it's pretty much clear about the undersizing with the OCT, but it's clearly that we are looking in interluminal area. We are taking interluminal pictures in both these modes, and we should know what we are measuring, EL to EL or lumen, and then talk about what we're doing in terms of sizing of stents.
Even recent ESC guideline 2018 clearly mentioned 10 to 15% undersize compared to IVUS. So that is the reason when you are considering the OCT size, it has the IVUS size like 4.5 to 4 square inch. This will be around 4.
Yeah.
That you have to 4 square mm. You have to 10 to 15% lesser OCT.
Yeah.
ASC guidelines clearly mentioned.
You see, but again, that is based on the 40 megahertz transducer, not the current HT transducers.
Yeah, regular IVUS. Yeah.
Any final comment by Gary and Jonathan Hill regarding early versus late acquired malapposition and its clinical significance and also the diagnosis by IVUS versus OCT?
Well, so OCT detects malapposition half the time, IVUS 15% of the time when at the end of a PCI procedure. But those have had no impact on events.
And any comment about the late acquired malapposition?
Well, I'd say that OCT is a good modality as it is acutely, but at a late stage to detect malapposition if it's there.
Okay, fine. Thank you, both the speaker, and let me go ahead because of the time constraint. So now we are going to have a live in box case, the role of imaging in acute coronary syndrome PCI, and going to be presented by Dr. Ajit and Dr. Vijay Kumar.
Okay, so before Vijay presents it, I just want to show this case as an ACS presentation of a graft, and Vijay will share the live inbox and read the OCT before and after the procedure, and we will have the discussions after that. Please go ahead, Vijay.
An old inferior wall MI has a bypass into 4 grafts in 2005, lemur to LAD, vein to diagonal OM and PDA. The angiogram shows a patent lemur to the LAD, and SVG to the diagonal is patent, an occluded SVG to OM, and diseased vein graft to the PDA. For a normal LV function, she's diabetic. That's the native coronaries. The left is, as you can see, occluded. The right is also natively occluded. That's the lemur, which is patent to the LAD. That's the patent SVG to the diagonal. And you can see that's the SVG to the OM, which is occluded, and the disease graft. He was on medical treatment, and we will go to the angiogram today. So can we have the hookup on the main angiogram? So you can see today that there is a diseased vein graft, which is supplying a huge PDA and PLV. There are 2 lesions in the proximal and the mid segment. They look atheromatous. The plan is to possibly protect the graft with a filter and then proceed with an OCT to show you what it looks like, and then plan a stenting across the graft. So with me is Dr. Vignesh, who's my colleague. There's the nurses, Frederick, my technician, and everybody to help me with this case. And so the first thing which I'm going to do is going to get a wire down, and this is a Xi'an blue wire. So we get the OCT ready, please. Small check. Small check. foul check. That's the plaque. We don't want to go there. Okay, now go to the other view back. So usually you take a vein graft, you take a RCA, you take a multi-purpose guiding because it gives you good support. And that's okay. Is it enable pullback? Okay. That's fine, no problem. Sinning. Inject now. Not good. Just let's see if it doesn't so. Otherwise, we'll have to do an inject. Yeah. Nice. Full of thrombus inside. The first shot, you only see the proximal and distal. I'm just going to put it in.
And can you hear me? Because can you hear me?
We can hear you.
Yeah, and this is a OCT image. Unfortunately, because we didn't pre-dilate it, we didn't get a great image. You can just see the blood swells distally. We started just beyond the distal lesion. So this is what we got. And if we keep seeing, and in the middle part, hardly any images, all blood swells here. And RT appears to be okay. And this part, we didn't get anything because it was done. We thought maybe we just get a plaque characteristics or to just rule out a big thrombus chunk sitting there. So, and this part again, it is the part that was in between two chunks of lesion there in SVG. It was just coming proximal. And only we could get imaging of the proximal lesion. So this is what we found. And it is degenerated here. You just see that this is the area we want you to focus. And probably this is a big recanalized thrombus here. You can just see the channels here. That's why even he wired, then it was finding it very difficult to go inside. Even though it appears like a fresh thrombus in angiographic images, and it is actually a ruptured plaque with a recanalized thrombus here. And we all know the main mechanism of graft failure is a plaque rupture. That is a main mechanism of failure. So any comments on this OCT?
Okay. So now
this is, may I comment?
Yeah, it's coming.
Say classic ACS presentation, even SPG grafts, they can present like a lipid-rich plaques, plaque rupture. This is more of soft plaque. Heel plaque is also there. And if it is sometimes we also find, I did a lot of SPG during acute MI also. Sometimes we find severe calcium in the SPG graft. Sometimes they may not yield with the routine balloons we use, open and see cutting balloon. But it's a classic atherosclerotic plaque and soft plaque rupture with the acute thrombosis. I think this patient can yield well with the simple measures without any plaque modification. That's my opinion.
Okay, thank you. Any other comments? Maybe we can.
Dr. Jonathan Hill, Dr. Kevin Cruz, any comment about the OCT in the venous graft or any specific finding which is different than the arterial graft?
I'd love Gary's perspective on this, because as we've applied OCT to a large number of our PCIs, including vein grafts, and then looking at stent failures in vein grafts, I've been impressed with the number of old vein grafts and how voraciously they calcify, which I think is an underappreciated clinical entity. It's underappreciated how to deal with it, and our interventional fellows don't even know it exists. And it's so Are there any studies on that, Gary, in sort of an evolving way to understand the importance of it?
So we published a paper years ago, an IVUS paper, obviously, on vein graft calcification. I think the first author was Castagna, Castanga, as I recall. But there is a time point, and again, now I'm dredging it up from memory. After about 10 years, the rate of calcification goes up significantly. So that's number one. Number two is, you know, the vein grafts have valves, and valves are also problematic. I'm not quite sure I understand what they look like on OCT, but that has to be factored into your differential. And the third is that sometimes if the veins are mishandled, they can get fibrosis that is as problematic as calcium, and they're almost impossible to expand. I'll see if I can find the calcium reference.
Yeah.
Thanks, Gary. Great.
So we go forward. And
there's more of fibrous here. I don't see much calcium on OCT.
Yeah.
Okay. So now the plan, what is the length from good to good? 68. So from the ostium of the graft to the... So maybe we'll have to put 2 stents. What do you think, Vijay? 68.
Yeah, if I can just jump in. It's Circulation 2005, volume 111, page 1148.
Thanks, Gary. That's great.
Yeah. Okay. Now you have to take this wire out. Yeah, take the wire out.
We're just putting a filter. It's a spider filter. 5 millimeter.
My question to Dr. Ajit Mullah sir, sir, if the patient is having a slow flow, no flow, are you using still glycoprotein 2B3 blockers? Because this is also one of the indication. What is your experience?
There's no data with 2B3A in vein grafts. So I think I don't use it at all in vein grafts. I can do if I can use it, because this has a good landing space. It's a big graft. Patient had a non-ST elevation MI, so I think
capture part of the filter ready, please. The blue part.
So that's what I use the filter with. Yeah.
Hey, Jonathan, are you on still?
Yeah.
Another stent ready, please.
So we have a 5 millimeter filter down there, and we just now trying to get the first stent down. It's a 38 4 millimeter stent over the filter wire.
I think there's disease there. I think that's okay. So we'll keep a 448 ready. 448
suppose
ready.
you find a recanalized thrombus in vein grafts.
448.
Do you think filter is essential in those type of cases?
Okay, go up.
And do you think we have to use filter in this case or no? Suppose your OCT shows
So we're going to put a second
recanalized thrombus
438
rather
stent
than
in.
a fresh thrombus or degeneration.
Well, I think, Vijay, there are two issues. One is thrombus and one is the atheromatous debris. Both could create Nori flow. So I would be happier if I get a filter down in a big graft like this. I would seek the comments from everybody else on this.
Just do an inject. Let me just overlap.
I guess when the filter comes out, you'll know whether it's been actually useful or not.
That's why we are
The other view, I just want to see the overlap, please.
One of the things with OCT, which is a disadvantage in this case, although I use it routinely and it would be my preferred modality, is you can't see behind the red thrombus. And so the degree of atheromatous material is somewhat obscured by the clot. And so the hazard to using the graft is minimal. I think the upside is huge. And it can capture pieces of clot also. So without question, I agree with the operators. I would have one down in this case.
lot of.
And it is a bigger size also.
So go to the other view. I can pull back a bit. Right to the obstum of the graft.
If you don't want to use filter in this sort of vein graft with such material, which is obvious, then that means you don't want to use filter at all. I think filter is mandatory in this case.
We thought it was mandatory and used it. Maybe just go.
But even if nothing comes out, Dr. Ajit sir,
and nothing
still I think we can't say that filter is useless.
Inflate.
No, most probably, if you find only recanalized thrombus and there's not much of degeneration inside, may sometimes we have tried few cases after OCT without a filter.
Still looking good.
They did well. Unless you have an extensive degeneration, thin cap fibrotheroma,
filter, please. Blue part.
You may avoid filter.
We used to pre-treat with diltiazem, verapamil, something like nicoranyl before. Are you doing it now? I don't think you are. Are you doing
it? Do it in this case.
In this patient.
Result is quite good.
Yeah, because we can't see any tissue prolapse, right? So with that type of, if it is thrombus, we should have had something inside the stent.
Is the Sion blue ready, Mark?
And the filter did not show anything in this.
Anything. So we pulled out the filter and there was absolutely no stuff in that. So it's just so unpredictable at times. And I'm not sure if anybody has any experience with the OCT-based vein graft.
And here you can just see that when we just tried to retry the filter, there was a deformation of the proximal part of the stent. Can you appreciate in between those two sutures? Now it is going in.
No, it hit the top.
It is because of the bias, I think, wire bias. If you push it, obviously
that retrieval, during retrieval, just there was a deformation that we have corrected with the 4-5 balloon later. Because this Boston stents are well seen.
That the balloon first.
We could easily
4.5 balloon.
So I think that the multipurpose guiding was just sitting on the stent, and when I was trying to recapture, I did deform it. I had to pull back the guiding and then get it down, and then I had to post dilate with the 4-5 in the proximal to avoid stent deformation there. So even you can see here, I was very careful in this time, but still I had to very carefully disengage the guiding to pull back to push that 4.5 in.
8, 9, 10, 11, 12, 14, 16, 18, 20.
OCT also guides like a native vessel, any proper plaque modification needed or not. Here it showed clearly soft nature and the plaque and the thrombus. And in such cases, direct stenting also very helpful. But sometimes the calcium with the thrombus will be there, a lot of calcium. That time we have to use the for any cutting balloon and open NC, and that time you can go into that.
The guide is very coaxial and there's hardly any flow back. So in such cases, if you use saline instead of contrast, you will get excellent images. And you can save a lot of contrast by doing with the saline.
This is what the final OCT, hardly we found any tissue prolapse inside. There was some, but not much inside both the stents. Almost clean inside. We expected, if suppose it was a thrombus, most probably both were recanalized, chronic thrombus rather than acute one, just to jail behind the stents. We could not make out any tissue prolapse. Maybe minor ones were there. Here you can see the minor ones, but stent was fairly clean, and his troponin next day was 0.02 or 0.03 something. We didn't have much troponin elevation also in this patient.
Vijay, I keep telling both operator and patient has to be lucky. Sometimes it could be the other way also.
Yeah, it is.
There's no way we can control it totally. Unfortunately, result came quite well here. I think.
Initially we thought we should treat this patient with, because the native was a CTO, so we should treat this patient with the heparin for some time before bringing him back. But fortunately, nothing has happened. But most probably it was a recanalized thrombus, what we saw in the proximal part, plaque rupture with the recanalized thrombus, rather than a fresh thrombus sitting inside. And as I told, there is not much troponin elevation. Also, we expected a lot of troponin elevation next day, and patient was absolutely asymptomatic, no STT changes also.
I think this case just demonstrated how sometimes vein grafts behave very oddly at times, but I think we need to protect most grafts if we can, and directly stent them very nicely to push the thrombus and atheromatosis debris behind the stent, so that and be careful there's no Swiss cheese effect by bringing the plaque protrusion back in and that embolizing. And protection, we try to use as many as possible in the vein graft. Obviously, need size, which is good, and we need also distance sometimes to keep the filter, which sometimes is an issue. Sometimes crossing a filter itself on the graft can embolize. So these are issues. I think an OCT is an excellent tool, and Vijay showed us how we do. I would like to take comments on if anybody would do this any differently, and what would be the steps differently that they would take.
What was the diameter of the stent, sir, which is taken?
We took 2 4s, 438 of 2, and then dilated it to 4.5.
Okay, as you said, no, you should try to take a maximum diameter, what is appropriate, rather than post-dilating. Here, I think focally at the lesion points, you post-dilated. But generally in vein grafts, we tend to, you take at one bigger appropriate size and avoid high pressure post-dilatation. That's what you said.
Yeah.
Great case, sir.
Thank you very much. And we could go to the next presentation. We can't hear you. Sorry, we can't hear you. You're muted.
So thanks, Dr. Ajit and the team for a nice demonstration of the OCT in saphenous vein graft intervention. And now let me invite Dr. Kevin Cross for his talk on role of OCT imaging in calcified lesion. Dr. Kevin Cross is an intervention cardiologist and the director of CTO and Complex Coronary Intervention Program at Brigham and Women's Hospital. He is an assistant professor at the Department of Medicine at Harvard Medical School. His clinical interest includes advanced treatment for obstructive coronary artery disease, optimization of antithrombotic and antiplatelet pharmacotherapy. Dr. Kevin, please.
Thank you. Thank you very much, everyone, for the invitation to participate in this wonderful meeting. I always like catching up with colleagues from India. There's a lot of overlap in terms of research and practicing. So again, thanks for having me with this excellent panel. So we're going to talk about the fact that calcium is a difficult entity in PCI. I think it's been alluded to already, and some of the concepts that I'm going to speak about today dovetail very nicely on the comments that Gary and Jonathan presented earlier. You know, it's well appreciated that calcium worsens long-term PCI outcomes in terms of stent failure and target vessel failure. And there's been many studies that show that even with second-generation DES, calcified lesions fare much less well from a patency standpoint. And Gary made a really compelling argument that stent failure is dangerous and kills people, and it's something that we need to try to avoid in our patients. So with that in mind, then, if you think about calcium, this is a paper which I think Gary and colleagues published in the 90s, well before I was in medical school, but it's long been recognized that coronary calcium is not seen well by angiogram, and it's much, much more sensitively detected with intravascular imaging. And when calcium is present, it's technically challenging. Lesions respond poorly, they dissect more, and our stents don't expand nearly as well in calcified lesions. And therein lies some of the underpinning of mechanism of why calcium is a predictor of MACE in patients that get PCI in the setting of calcified arteries. As was spoken about earlier, this is data from CLIO PCI, which demonstrates quite compellingly, as Gary already alluded to, that small stent area and underexpansion are the main driver of MACE. So by supposition, if calcium prevents us from expanding our stents well, and we know that underexpansion is the main driver of MACE, it's something that we need to think carefully about as we strive to have optimized outcomes for patients and make their stent implantation durable. And just to speak earlier, at least, echoing what was spoken about before from Clio PCI, for which Gary, as I recall, is the co-author, malapposition has no hazard of MACE whatsoever. It really is all about the stent size, inlet and outlet disease, and distal edge dissections. And those are the things we should be paying most attention to when we're thinking about the role of imaging in helping to potentiate the durability of PCI in patients that are getting stented. The other unfortunate problem is that in-stent restenosis and stent failure are common. It's currently 12.5% of all US PCIs are done for in-stent restenosis. This is despite the advent of second-generation DES, where we continue to see this being a major problem in practice. And as Gary spoke about, TLR is associated with a major mortality hazard. So with that in mind, as we look at why stents fail, this is data from the CRF group that demonstrates regardless of whether your stent fails early or late, underexpansion is very common as a mechanism of stent failure. We looked at this internally in our center in a particularly difficult set of patients that have multiple layers of ISR that are sent to us for brachytherapy. And we see that 73% of them have stent underexpansion if they have multi-layer ISR, defined as 80% expanded or less relative to the reference segment. So in this particularly difficult patient subset, for us, underexpansion seems to be the norm in patients that fail multiple layers of stent and are referred for radiation therapy because we do not yet have drug-coated balloons in the United States. This is already spoken about at length. Imaging cuts stent failure in half, randomized data, and the mountain of evidence that Gary already alluded to earlier in the session. So with that in mind, how imaging works, as has been shown in multiple meta-analyses and several studies, is it increases stent MLA. Bigger stents last longer for patients. And understanding calcium burden and how to remediate that is a path toward getting stents to expand well. In terms of trying to improve adoption, several colleagues and myself participated in an exercise to come up with a workflow to make image-guided stenting with OCT easy. We won't have time to go into this today, but we've had several sessions on this with Indian colleagues over the past several months. And MLD Max is now, at least in the US, a go-to prescriptive strategy in how to do an OCT image-guided PCI. It actually works really well for IVUS too. The first step on your pre-PCI OCT is to plan the case, with M in MLD Max standing for defining the morphology, understanding the calcium burden, and taking appropriate action to modify when necessary. And on the back end, we do a post-PCI optimization, looking for things that we know matter, as was spoken about. Medial dissection and expansion being the main things, and we look at apposition only to the extent that it can make it difficult to retreat a patient if you had to come back, because minor amounts of malapposition do not have a major MACE hazard, as Gary spoke about quite eloquently before. In terms of the PCI planning, the first step is define the morphology. And there are many image-guided algorithms on how to deal with calcium. This is one of many, particularly nice. It talks about where the calcium is, whether it's superficial, whether it's nodular. The type of calcium when possible, if you can get a catheter across, to help us decide what to do from a vessel preparation strategy so we can get our stents to expand well. So what are the indications for atherectomy? We really want to consider, as we move into the mild to moderate to severe calcium, in a scenario where calcium is going to impact stent expansion, we need to do something about it before we put our stents in. This is one of the most useful papers in my mind that's been published in the past 3 or 4 years in every single image-guided case. This is a calcium volume index. It came from the CRF team, and using a scoring system that incorporates the angle of calcium, the thickness, and the calcium length, we can finally start to have an intelligent conversation about what is an atherectomy case, because as you get to 3 or 4 points on the score with OCT, you can see that your stent expansion starts to drop off precipitously. So moving forward then, thinking about the value of OCT in defining calcium, this is what calcium looks like by OCT. And I think by the fact that people are attending this meeting, they're probably facile at reading calcium by OCT, but it does look very different than IVUS. It's a well-circumscribed, darker segment in the artery that's got well-defined borders. One of the nice things about OCT is you can see things like nodules very well, and you can start to get an idea of the thickness of them, because OCT allows you to measure calcium thickness much better than IVUS, because IVUS tends to shadow behind the calcium. And so one of the potential values is understanding thickness in a higher fidelity way compared to IVUS, where it's harder to do that. Calcium-dependent vessel preparation involves being able to shave off the thickness of the calcium to be able to allow the thickness of the calcium to be less, so that when you balloon it, you're able to crack the calcium such that your stent expansion is optimized to 80% or more, which is the current goal under the premise of an MLD max guided PCI. This is what calcium fractures. But in terms of comments earlier about how easy it is to learn OCT, because of the higher resolution, there's a lot less nuance of interpretation. The high res allows you to know what you're seeing with great clarity. And I do agree that there's a lower learning curve with OCT compared to IVUS. With things like calcified nodules, which are a particularly difficult entity to deal with interventionally, you can see a nodule here. We start to think about some of the mechanical atherectomy devices and their ability to sand off some of the volume of these so we can get nice circular stents, and also to reduce the chances of vessel rupture when we stent these lesions and post-dilate them. So understanding nodular calcium is an important part of understanding how best to treat an artery, with an idea that nodules deform stents, they keep your stent area from being perfect, and they also are associated with rupture. So if I see a nodule like this, for me, it is almost always a case to try to do some amount of debulking to optimize the stenting result. Once you've chosen your stent size and your vessel prep strategy and implanted the stent and post-dilated it, on the back end, as I spoke about, we look for the presence or absence of medial dissection and really focus on expansion. The fact that under the common image-guided workflows, acceptable expansion is an MSA that's greater than 80% of the distal reference segment and proximal reference segment, but optimally we want to have it be more than 90%. And I think we're advocating that this becomes a part of workflow in any image-guided PCI. We recently looked in a study called Light Lab to understand the impact of MLD max in everyday practice in 12 hospitals with over 40 investigators. And what we saw is that compared to planning the case based on the angiogram, the OCT information changed decision-making with vessel prep up to 28% of the time. And so over the course of the pre-PCI and post-PCI planning, OCT changed what we would do in terms of understanding the approach to a case very frequently compared to an angiogram guided plan. It's not surprising. This has also been shown in similar studies for intravascular ultrasound. In cases where the OCT found calcium and the angiogram didn't, it led to a 47% change in the vessel preparation strategy. So understanding that OCT is much more sensitive for calcium, it's not surprising that when we use the OCT, we see it more than we do on the angiogram, and it changes what we do in terms of our vessel prep. There's a little comment earlier in terms of the value of imaging. Additional data from the later phases of Light Lab demonstrates that after a little bit of practice, as we move from a baseline phase in this workflow study to the later phases where operators had done about 20 cases, a pre and post OCT only takes 10 more minutes to guide the case. I would propose that if it took you 10 minutes to get it right, and use a technology that helps your patients to have a 50% lower chance of MACE, that is time incredibly well spent. It's probably the most important thing we can do for our PCI patients. So with that in mind, I just have a couple cases which demonstrate the MLD max workflow, and I think illustrate, at least in my mind, the value of imaging in terms of modern PCI. This is a relatively simple case. It's a 68-year-old gentleman with renal disease, obviously one of the risk factors for coronary calcification. Chest pain and a positive stress test. The lesion of interest is this proximal LED stenosis there. There is MINS grade calcium that's moderate to severe on the angiogram, but I think understanding what we need to do with MLD max is incredibly important. You can see as the OCT pullback comes, the OCT co-registration is helpful. And as we look at this, there's a rind of greater than 0.5 millimeter of calcium. I won't belabor the pullback. I'll tell you it's greater than 5 millimeters long, so that without question, in this particular example, the calcium volume index score is 4. This is a case where you're likely not going to get great stent expansion unless you do additional vessel preparation before stenting. In this particular case, we decided to use orbital atherectomy to atherectomize the plaque, a 1-to-1 size predilation balloon in the proximal and distal segment, and then we treated with stents that were appropriately sized to the EEL, and then went ahead and post-dilated the 475 and 40 distal. On the initial post-PCI OCT, you can see that our stent expansion is not entirely perfect yet. One of the nice things about OCT workflows is because the measurements are made automatically, this is really quick and easy to do. That's why it only takes 10 extra minutes to do a perfect MLD max guided PCI. With the co-registration, I know exactly where the problem is. I remeasure the proximal and distal EEL. We go ahead and do further optimization with a 508, only one balloon inflation, because I'm only trying to treat this under expanded area. And with that, we're able to achieve greater than 80% expansion. So I chose this case really just as a simple way to outline an MLD max workflow in a scenario where we're having to make decisions about calcium modification and trying to get an optimized stent. And then this is the final angiographic result. And I joke with my fellows that the angiogram is not important anymore because I see way more than I need to with the OCT in terms of how I did with regard to the high fidelity or low fidelity of my stenting. So this is a little bit more of a complicated case. It's a 71-year-old gentleman who came in with an acute coronary syndrome. He has normal LV function and he has anomalous coronary anatomy. His left coronary originates from the right cusp. And for that reason, his native right coronary, which you can see here, is absolutely huge. It effectively works as a circumflex, and there's a tremendous burden of calcium here. This is some of the worst calcium I've seen in practice. I hope it comes across angiographically from across the world as I present this today. And so approach to this was, because of the size of myocardium, I wanted to use a temp wire. We did the 7 French radial and used an antegrade wire escalation strategy and crossed quite easily and swapped out for an orbital atherectomy wire. We did orbital atherectomy extensively, 14 runs, 7 on low speed, 7 on high. And with that went down with non-compliant balloons, which were completely constricted and had no interest in opening. We did an additional 9 runs of orbital on high speed in areas where the balloons wouldn't expand, again dilated and found there was significant constriction. This is a 6 millimeter of an angioscope balloon, which has a waist. And the question then becomes, what next? I think you cannot treat this patient unless you understand what's happening inside the artery. We went ahead and did OCT, and you can see despite 23 runs of orbital atherectomy, I still got over a millimeter of calcium, which is circumferential. So this is a really nice opportunity to consider a different strategy. You could go with more orbital. You could go with a large rotoburr. We did not yet have coronary shockwaves. So we decided to take a peripheral shockwave balloon. We were just barely able to deliver it into the constricted segment. And you can see after 15 pulses, the balloon starts to pop open quite nicely. We're able to prep the vessel. We were able to get good expansion of balloons on further predilation, and we overlaid several Xience drug-eluting stents. Unfortunately, after post-dilating the proximal segment, my 5 millimeter balloon ruptured, and I had this odd filling defect seen on the angiogram. When I can't tell what the angiogram is showing me, I always image. And you can see, interestingly, we have acute stent fracture shown right here on an area of nodular calcium. Gary and I have had lots of conversations about the difficulty of nodular calcium. One of the things it can do is cause stent fracture. This gap is about 2 millimeters in the segment. I can tell you for certain I overlaid the stents without question. This was in the middle of the stent area. And so in this area of fracture, I don't have a great answer in terms of what to do this, but I dilated it some more and put another Xience stent in. We post-dilated it with a 5 millimeter balloon, and then this is the final angiogram picture. Because I think, both in the case, once we got across and we're able to dilate, I routinely, and I think many people in this conference do, it doesn't matter if you image up front. If you have to dilate to allow you to get the imaging to then further inform how your case is going to go, especially with CTOs, as Jonathan showed, we routinely will do antegrade wire escalation cases, balloon to be able to deliver our OCT or our Ibis catheter. People talk about the fact that OCT is not used much in CTO. For antegrade wire escalation cases, once you balloon, effectively, it's like any other lesion. We use OCT routinely in those cases. I actually have a third case to show, which is an OCT guided CTO case. We probably won't have time to do that today, so I'm just going to get very quickly to the summary so we can catch up a little bit for this session. So by way of summary, calcium reduces the durability of PCI revasc and impacts stent expansion. Imaging clearly impacts procedural decision-making, vessel preparation, and atherectomy utilization. This is data from our Light Lab study. And most importantly, it only takes 10 minutes to do it. Modern image-guided workflows help to assess calcium burden and morphology so we can guide vessel preparation to optimize stenting results, and most importantly, get stents that are going to be durable and improve the outcomes of our PCI patients. Thanks very much for the invite to be here today. I really appreciate it.
Could I just add one quick comment? I mean, Kevin's review of calcium was fantastic. What's not very well appreciated is that the calcium is not homogeneous. The most superficial elements are the hardest. So even though we like to see a marked reduction in calcium thickness, just getting rid of the most superficial elements can make it easier to expand a stent.
Thank you. I think we will close the session, Rajesh.
Yes, please.
Okay. Thank you, Dr. Kevin, for showing an excellent cases. And though images look pretty, but we need to work very hard in the lab to get those. I think OCT goes a long way in getting and optimizing our results. And thank you for the excellent cases. Thanks. And
appreciate the invitation.
Thanks each and every speaker, chairperson, and the panelists. Let's move to the next session about the calcified lesion intervention. And let me invite chairperson Dr. Ashok Seth, Dr. Pratap Kumar, and Dr. Jonathan Hill to chair the session. And the panelists of the session are going to be Dr. Indrajit Monga, Dr. Arun Kaushik, Dr. Tanuj Bhatia, and Dr. Rupali Khanna. Over to Dr. Seth and Dr. Pratap Kumar for the next session, please.
You're muted, sir.
I said, that was a great, tremendous lecture. And that sets the stage for the next session, clearly. Calcified lesion intervention. And he's showed some tremendous cases. I probably will bring certain aspects up as we continue this discussion. And I think in the interest of time, we should go on to the next lecture by Dr. N.K. Mahesh on imaging in calcified lesions. More practically, how do I actually plan the case? So over to Dr. Mahesh.
Good evening, everybody, and thank you for this opportunity. Am I audible, sir?
Yes, you are, and we can
sir.
see your slides.
Thank you, sir. So the topic given to me is imaging in calcified lesion. How do I plan? There will be so much of overlap in most of the talks that I'll try and stick to what has exactly been given to me. So what are the multi-modality imaging for cardiovascular calcification that's available with me? Unbelievable. There is grayscale intravascular ultrasound. There is integrated backscatter ultrasound, intravascular ultrasound, virtual histology IVUS image. There is OCT. This is the histopathology. There is a PET-CT image that can be this. There can be a 3D merge MRI which can show me the calcification. There can be a non-contrast CT and a non-contrast CT. So there is actually a spectrum of equipment that we have for imaging of calcification, whether it be in coronaries or other things. But practically what is available with us is these four things. There is coronary angiography, CT, IVUS, and very few places virtual histology, IVUS, and OCT. So when you compare the imaging modalities, you have the point system, if you can put a plus for their ability to detect the thing. The calcium and angiogram, the localization and the quantification get a single plus in CT in coronary angiography. In CT scans, surprisingly, you get 3+ in all the three modalities of assessment. And in IVUS also, you get superficial calcium detection is the best in IVUS. It's got detection of coronary calcium. It's got localization 3+, and quantifications, unfortunately, is less because it shows a shadow behind the superficial calcium. If you have a virtual histology IVUS, then the quantification becomes better. And for the OCT scores distinctly ahead of all the modalities so far available with us for in terms of imaging for calcium. So if you go to the comparison of histopathology and the IVUS images and the OCT images, you can see this is the calcium. You can see that in the IVUS you can see the proximal most part of the calcium is a bright spot. Behind that there is a little bit of shadowing and not seen. At the same time in the OCT you can actually see the exact amount of the calcium that's been said. The size and the dimensions can be done. and the arc and the dimension can be done easier with an OCT as compared to an intravascular ultrasound. If you compare the images of a superficial calcium equal, both of them can be identified very easily. A slightly deep calcium, both of them can be identified easily. Now this is actually a fibrous block with maybe a little bit of specks of calcium, wrongly identified as calcium by the IVUS in this case. That is one fallacy that can take place. This is a nodular calcium identified by both. Here you have a nodular calcium which is correctly identified by the IVUS, but there is a suspicion that it looks like a red thrombus in the OCT. So nobody is perfect in the imaging, but you have to have experience and you have to decide what is your imaging that you would like to follow for your cases that you would like to do. So this is the distribution of calcium as seen by the OCT. You can see superficial, deep, and nodular calcium. And this is the coronary calcific nodule, as you see. It's more clearly, it's definitely identified distinctly by the IVUS images, more clearly defined by the OCT images. And this is a virtual histology of the IVUS. If this comes through, we'll probably give a run for money for the calcium detection by OCT. So this will be discussed, I'm sure. There's going to be a lot of discussion on this topic. So I'm just skipping this slide. This is the scoring system, already been mentioned by the previous speaker. So how do I go about it if I'm using OCT as my initial imaging? So I would like to do an image provided there is space for the catheter to go through. I divide it into deep calcium, superficial calcium, or nodular calcium. And then depending on applying the score of arc 180 degrees or thickness and the length, I decide on what weights to be done by cutting balloon, what modification I need to do, intravascular lithotripsy, depending on what class this calcium comes into. And once that is over, at the end of after the modification, plaque modification has been done, you have to image and you have to image to identify exactly how much of plaque modification you have done. And if there is you're unable to cross the catheter in the first place, you modify the plaque and do this. And once OCT is done, you decide on the calcium has been fractured and the bed has been prepared, only then put in the stent and take a post-stent view. The point here is that if you have not prepared this step very clearly, you will land up in trouble in the next step of deploying the stent. And after that, whatever you do, if you have not prepared the bed properly, you will not get a good expansion. So this is how the IVUS, this is a demonstration of the capability of very well done IVUS. This is the lesion, this is the area C, and this is the D. This is the pre-IVUS, immediate images, then post-rotablation, then post-orbital atherectomy, then post-balloon, and post-stent. So you can see that all the areas, all the dimensions, all the small facets can be easily picked up if done correctly in expert hands. This is one slide I just want to tell you: calcium detection among angiography, OCT, and IVUS. OCT, IVUS, IVUS picked up all the calcium that was picked up by the OCT, and there was no misses there. However, in IVUS, there were 26 cases which the OCT didn't pick up, which the IVUS picked up. How big it was, how thick it was, how normal it was, how abnormal or how significant it was, a different chapter. But the sensitivity and specificity for just picking up calcium is best with IVUS. However, there was at least one case where the angio picked up and the IVUS did not pick up. And there were 5 cases where the angio picked up and the OCT did not pick up. So you have to have a collaboration of an angio, an OCT, or IVUS to identify and quantify the plaque burden very carefully. This is the graph which is the flow chart for how I would go about it. Mild calcification, balloon predilatation, stent implantation, optimization with IVUS and OCT, IVUS and or OCT. Moderate to severe calcification, you do an OCT assessment, as I said, put the score in, put the calcium length, put the thickness, put the calcium mark. And if you're doing IVUS, you should add these 2. That is calcium thickness. In case of IVUS assessment for calcium more than 5 millimeters plus calcium more than 270, add an extra point to the score. So that is how you have a scoring system for IVUS and OCT. The OCT scoring system has been discussed. The IVUS scoring system is going to be discussed, so I'll stay out of it. So this is the slide which tells you 2 things. One, pre-procedure, you have to do an imaging. Post-modification of the calcification, you have to do an imaging. And post-deployment of the stent, you have to do imaging. This slide I stole from Dr. Ashok Sethi the day before yesterday. He put it up for 5 seconds. I took it from him. Thank you, sir. this is mild to moderate calcification. Again, intravascular imaging. If the lesion opens and if it is straightforward, please go ahead and stent it. If there is significant residual stenosis, you have to do an intravascular imaging to decide what to do next. In severely calcification lesions, balloon crosses, imaging catheter crosses, do an intravascular imaging. If it does not cross, then modify it with whatever method you choose as the best methods, as been told by Dr. Kevin. And then pre-stenting, you should do an intravascular imaging, and post-stenting, you should have an intravascular imaging for optimization. So post preparation and post-stenting for optimization. This is the ideal flow chart that I would follow in case I'm stuck with a case which is heavily calcified and needs imaging. What is the future? The future is like this. This is how the lipid pool, the stent struts, and calcification, intima, media, adventitia looks in an IVUS. And this is how it looks in OCT. You can see the struts more carefully. The stent struts are distinctly seen. The calcification is more deeply seen. Intima and media are seen, and red thrombus is also seen. You can compare the images of the IVUS and the OCT. Whichever you're familiar with, you could do it. But the future is a combination of these two, which is coming as a fusion of OCT and IVUS. It is going to be a little bulky thing, I would imagine, as compared to that. But of course, the images would have the plus points of the OCT and plus points of the IVUS. Until that time this comes through and gets established, there will be an OCT group fighting with an IVUS group to decide what will be your next imaging strategy. My only suggestion is that whatever is your imaging strategy, please do one imaging before you start off with the case, one imaging after you prepared the bed, and one imaging after you deployed the stent. Thank you. So you're not audible.
That is a tremendous overview. And, decision making is important. You would have noticed that in my real life workflow, where I'm very, a proponent of imaging, I do believe that mild to moderate calcification should just be on one side, not just mild calcification. Mild to moderate calcification will give way with most of the devices. And only if you have another, if you can't dilate that lesion with a near optimal size balloon to 20 atmospheres, you need to go to other methodologies and start assessing by imaging. But clearly, severe calcification in daily life is getting more complex. It's getting more and more complex. The real world lesions are not just severely calcified, they're complex and severely calcified. There's no doubt that needs imaging. By the way, one of the things I hope you have time, because I think Indrajit Monga should comment on this. One of the important points about what hasn't been mentioned is it's not just the issue about X tool versus Y tool. All the tools are complementary in real world cases. But the important aspect is that imaging also provides safety. When you go to ultra high pressure balloons, following stent implantation, where you want to get optimal results, and you have some residual stenosis or residual MSAs, the only thing which saves you is because you have imaged, because you can go up to 40 atmospheres with optimal size balloon and still not have a perforation or a vessel rupture. But if you haven't imaged it and you do that foolish thing of going to ultra high pressures, you will actually have a perforation. And that's the most important thing also in mind. So it's not strategies, it's the tools, it's also the safety of the patient. Okay, are there any comments from my panelists? And of course, Pratap, yourself, please.
Well, actually, no comments, sir. Actually, it was wonderfully told, as well as you commented very well. So I don't know, sir, anything. No, actually, exactly done. Everything is done.
Perfect. And anyone from the panel has any important comments? But we must try and stick to time as well. So,
good evening, everyone. One more thing that I would like to discuss is when we do have purely a eccentric calcium, should we go in for such techniques? Because if we have just an eccentric calcium, we could have an adequate stent area after we optimize the stent, although it might be an asymmetric expansion. So
a very good question, and I just let Mahesh address that issue. It's an important observation.
So the plaque modification strategy depends on your calcium being after you have to identify what is your calcium distribution and the calcium thickness and whether it can be tackled. For example, if it's just a nodule which you're talking about and it's very eccentric, orbital atherectomy is the only choice we have.
Yes.
So whatever else you do, you may do a rotablation with a wire bias and you may get away with it. But modification of the calcium is dependent on what is whether the mild calcium, moderate calcium, the thickness of the calcium, and the distribution of the calcium. So you have to choose your modification tools adequately. If you cannot get it modified despite your best efforts, then I probably would settle down for a very good stent area at the end of the case.
So we'll address this issue. In the interest of time, we'll move on. But I think I would like to address this slightly more as we go along. So let's just go to Jaswal for the role of imaging in calcium scoring. And Pratap, you could actually moderate the next couple of talks, please.
Sure, sir. Sure, sir. Jaiswal, please.
Are you able to see my slides?
Yes.
Could we go on to the slideshow, please?
Yeah, so the role of imaging in calcium scoring. We all know that stent under expansion is the most robust predictor of stent restenosis and early thrombosis, even in the new generation drug-eluting stents. And PCI of calcified lesion is associated with a higher prevalence of target vessel revascularization and MI, perhaps related to stent under expansion due to moderate to severely calcified plaque and inadequate lesion preparation prior to stent implantation. The current therapeutic options such as cutting balloon, scoring balloon, rotational or orbital atherectomy, or excimer laser angioplasty, or for that matter, IVL, may modify a severely calcified lesion before stent implantation. However, there are no clear-cut guidelines to indicate the necessity for calcium modification. And one difference I would like to mention is that unlike IVUS, optical coherence tomography can penetrate the calcium and it can visualize the calcium thickness better. So this is how it looks in case of deep calcium, which is non-luminal. There is a presence of a thick cap, and then there is a calcified area. In superficial, minimal or to no fibrotic layer, very little fibrotic layer, and depth of the calcium is usually measurable in majority of the cases. Nodule normally appears as a luminally protrusive, and many times it is associated with a thrombus as well. So this is the calcium scoring, where you take the arc more than 180 as 2 points, thickness more than 500 millimicron as 1 point, and length more than 5 millimeter, one more score. So if calcium score is 4, there is always high risk of stent under expansion. Lesion preparation strategy needed to facilitate plaque modification and calcium fracture before stenting. Use either IVL or orbital atherectomy or rotational atherectomy as per indication. I'll not go into this MLD max because this is something which has been repeatedly discussed, and even the SLOSA protocol. Of course, if the lesion is non-crossable, then we have to go ahead with atherectomy. And since rotational atherectomy is the only atherectomy available with us, so that's the option straight away whenever the lesion is, non-crossable. But if it is crossable, then we must do the imaging and define whether it is deep calcium, superficial calcium, or nodular. In case of nodular, again, orbital atherectomy is something which is going to help us. But if it is superficial, then we look at the scoring. And if the score is less than 4, then we can go straight ahead with the NC balloon or the cutting balloon or scoring balloon. And then we can do the imaging to see whether the lesion has been cracked. And on the contrary, if it is not, if it is more than 4 and it is balloon crossable, then IVL should be done. And if not balloon crossable, then definitely atherectomy is the way forward. And then we again image, again remodify if not adequate cracks have been created. One thing I would like to mention here is that following IVL, Most of the times, at least I would like to understand from other senior guys also, whether I'm correct, but most of the IVL cases, I could not see macro, cracks. They were very gentle, very fine. And most of the cases I did use the cutting balloon. And after that, the stent expansion was pretty good. So I would definitely like to have discussion later on this point. But in most of the IVL cases, I could not see major cracks, but the calcium had relented. So this is the basis of this scoring is Akiko Fujino et al. Article in which they had clearly shown that this is an example where it is all around, nearly all around, but very thin calcium. So without modification also, it could be cracked and the stent could be deployed. Angle was around 360, thickness was less than 5.5 millimeter, and length was also less than 5 millimeter. Calcium score was 2 and expansion was 99%. And on the second is a case B with calcium score of 1. One small area, thick nodule, it is around 1100 millimicron, length is 4.3, score is 1 and expansion was good. On the contrary, the third case, which had an angle of almost 312 degrees, thickness is pretty big. It is to the tune of around 1400 millimicron, length is 11 millimeter, score was 4 and expansion was only 68% without plaque modification. So this underlines the importance of plaque modification in such cases. So case number, I'll quickly go through the details. 60 years old female presented with unstable angina with the regional wall motion abnormality in inferior leads. We fixed the RCA, which was not badly calcified. Then we had done the staged angioplasty to the tortuous, heavily calcified LED. There is history of another member of the family at the same age, around 60-61, who died during plaque modification with rotablation to the LED. So they were particularly careful or cautious about the rotablation. So, and this is how the calcium was quite tortuous, long disease. So, but it was balloon crossable. So as per protocol, we dilated with 2 millimeter balloon and then tried to take the image. Because of the long tortuous lesion, the contrast clearance was not happening. But despite that, reasonable calcium and wall analysis could be done. So here we have multiple areas of superficial as well as deep calcium. Again, here we had deep calcium. So we modified the plaque with the IVL 310 at multiple places. This was the area which was not relenting. And here, after doing imaging, I'll give you the summary. This was the kind of calcium, at different levels, Arch was right up to 270 at places close to, close to 300 also at places, and quite thick calcium. This was after IVL, and as I mentioned that there was hardly any macro, the sections or cracks which were visible. So then I used the cutting balloon. Few cracks seen after IVL and cutting balloon, but no major cracks seen, but very good expansion. And when we did the OCT finally, the lumen was not exactly circular, but the MLA was quite satisfactory at all the levels. The only difference was that in the left main, there was gross stent malapposition, which was fixed with 5/8 balloon. And then we cross-check the left main because I'm very sensitive to, hanging struts in the left main. If you have to re-intervene, you have a lot of problem. You tend to go abdominal. So this was the final analysis. Optimal stent expansion across the entire segment, no medial dissection on edges, no malacquisition, no tissue protrusion. And then we, after, optimizing in the left main, there were no under expansion or malacquisition. So this was the final picture. Quickly, another case. 4 years ago, left main DVD, refused surgery. So culotte technique for left main bifurcation. Now, 4 years later, he comes back with the anterior wall MI, end STEMI, troponin in thousands, DOS ECG changes, ejection fraction 20%, moderate to severe MR, very sick, refused surgery again. Surgeons were also quite reluctant to take him up. So we thought of, we took up for intervention. So after OCT, this was the image. The reason was a lot of calcium there. We didn't have imaging in the first case. So now we modified this plaque with a cutting balloon. This is a kind of huge calcium which was all around, grossly under-deployed stent throughout. So deployed a stent, post-dilated, and this was the analysis. Post-stent to circumflex to left main, all along, good expansion. And then I was quite concerned about creating, 4 layers of stents in the left main. So since the LAD to left main, particularly this area was not badly, there was diffuse neointimal proliferation all throughout. The area was not very bad. So I just did the skirting of this stent with DEB in LAD. And a non-compliant balloon in the circumflex, optimize the ostium, and this was the final one from, and the analysis in short. I know the LAD is not great, but to avoid 4 layers of struts in the left main, I did not make it bifurcation again. This was the final angiographic image. So just conclusion, very short. The evaluation of calcium by IVUS is limited because of high intensity reflection with acoustic shadowing, which precludes the assessment of thickness. In contrast, because it can penetrate calcium, measure calcium thickness and assess the 3D extent of calcium, OCT has the potential to assess calcified plaque and quantify the amount of calcium better than IVUS. Although OCT assessment of deep calcium also has certain fallacies because many times, the depth may not be correctly assessed. OCT-based calcium scoring assesses amount of calcium that might prompt the interventional cardiologist to consider plaque modification pre-stenting. However, we need more literature with RCTs in this direction to validate further the utilization or use of OCT for calcified disease. Thank you very much.
Sir, can I just go here?
Yeah.
Thank you, Jaiswal, for the wonderful talk, but I have to make 3 comments. One, you told the Akiko's cases, actually, she was telling case 1, case 2, case 3. I personally feel that any calcified things which I see in any imaging, I will definitely go with the preparation of the lesion is very important, whatever is there, whatever is the outcome, even if it is a thin rim of calcium or a thick rim of calcium. Number 2, you told IVL. IVL usually softens the plaque rather than breaking the calcium. So the cutting balloon and IVL makes the difference. Third thing I just wanted to tell you, in the last case, what you have shown, I personally feel that ejection fraction is low in an LMC intervention. I prefer to use IVUS over OCT. These are my comments. I think Seth sir make some more comments, sir, please. Sir, you are unmute, sir.
Yeah, I was just saying, Pratap, great comments. I was just going to move ahead because of the interest of time, because it's going to be similar calcification, imaging, and management strategizing talks. Maybe we'll have time at the end. The only thing I would comment is, by the way, in CAD3 also, 70% of the patients showed fractures, 30% did not, because they have microfractures. That is why Pratap said it softens up the lesion for adequate stent expansion. You may not see huge cracks and fissures, but you commonly do that. More complex patients, you definitely see, if you deliver enough pulses at a point. What happens is that we have a long lesion, we tend to ration our pulses all across that long lesion. So we're probably softening it up rather than creating huge fractures, which would happen if we delivered all the pulses at a particular point. We could move ahead and then Dr. Selva-Mani, how to approach calcified lesions with imaging guidance. Over to you.
Sir, he will be talking on calcified nodules, sir.
Okay, calcified nodules. That's going to be interesting.
Yeah. Good evening, everybody. Thanks for the opportunity. Good evening, Chairperson Ashok sir, Pratap, and all seniors there, Dr. Kirti there. And I was requested to talk on my experience on calcific nodule. So this is actually a very last moment request. And of course, I'll try to show what experience we have. I think the perfect management of calcific nodule is controversial. We still really don't know. And the options include probably high pressure balloon, IVL, rota, laser, and orbital atherectomy. Probably these are the options which are available. Coming to the diagnosis, imaging is very, very important. As you know that this is how you pick up a calcific nodule on OCT and an IVUS. And whenever this is a very classical nodule seen in an OCT image here. Whenever you see an angio like this, for example, it is how to make out a nodule and an angiogram is also very, very important. In angio, you cannot be very precise that you have a nodule at the spot, but you should always suspect that probably in a calcified lesion, you are going to get some areas of nodules which you should be eager enough to just look into that, because that is what is going to create trouble. So somewhere in an angio like this, where it is diffusely diseased, see here, and in an angio like this, it's a severe calcium, probably here in this area or here, probably we are going to have a nodule. Let us see what happens on imaging. This is our routine probability. Look at the similar angiogram here. A severely calcified disease, long calcified lesion, and then probably there are certain areas you will be having a calcific nodule. So this is one common thing in an angio, but imaging is the best to diagnose calcific nodules. So this is a case which I did here in ACS, and then this is what the angiogram was looking. And we were probably, this was a bit almost 3 years back that I have done this. And what happened is we dilated with a balloon, and then I have done a OCT study there. So in OCT, so this is something like this. You can just correlate what is happening here. Just concentrate at this point. When it comes here, this is what is the calcium there. So initially, because it was something like an ACS, we did not concentrate much on the calcium. What I did is I just balloon dilated it and went ahead. And this was the OCT imaging of that calcific nodule, clearly seen there. But anyhow, we did not concentrate much. And the patient, we went ahead and I put a stent there. So what happens after putting a stent there, I just try to dilate with whatever balloon I have. It is not yielding. And there are areas of malapposition. Stent is not getting opposed here. And then this is what I got. But remember, if something like this happened, what I am very cautious is, I really do not go up with very high pressures. Probability of having a rupture opposite to this nodule is very, very high. So that is one point you should be very careful when you are treating a calcific nodule like this. somehow you have just landed in this condition where you are not getting good apposition. Still, if you have an adequate stent area here, I think these patients, they do well. So this is almost 3.5 years back. I have done, the patient is still doing well in spite of this calcific nodule being left there, some malapposition there. And anyhow, I was not very keen in still over dilating and having a perforation there. That's a very important point you should remember. And this is the angiogram final result. Angiographically, you cannot make out whether there is malapposition. If it doesn't pick up, it's only imaging which picks up malapposition. And coming to another similar case, he had a very difficult tight lesion. And we tried to put a wire and then try to cross it with a balloon. Balloon was not crossing at all. So the next option was to do a rota. Did a rota with 1.5 bar there. And the balloon dilated with a open balloon at that spot. And this is the OCT you get here. See here, this is the calcific nodule which was present at the ostium or the distal left main, which was preventing the balloon to enter. And what has happened is, this is the OCT catheter that represents the wire. So there has been a good wire bias there. It has been near the nodule here, and this rota has clearly burnt the tip of the calcific nodule. So this is the spot in the longitudinal view, and this is the spot in the cross section where you have a clear effect of rota which has burnt this calcific nodule. And the patient was stented, and this is a post-stenting images. Unlike the previous case, which I showed that there was no malapposition, there is no under expansion, very good expansion at the calcific nodule site. And this is the angiographic image after the stenting in this patient. And this is a very recent case. I was doing it in a live workshop some 2-3 weeks back. So look at this. If you get an angiogram like this, just concentrate on this angiogram. We are probably going to have a nodule here and here. And when I try to cross the microcatheter to change to rota, even microcatheter did not cross this area. It was so tight there. So then I had to somehow with difficulty crossed with a rota wire. And here what I have done is I have selected a 1.75 bar. So I have taken a 1.75 bar here. Basically, whenever there is a nodule like that, and then probably if you are not sure, if you take a smaller bar, probably if it jumps into that, you can have a stuck bar there. And in many times, if a nodule is there, if you upsize the bar, probably it might go and touch the nodule. That is the thinking. So that's why I took a 1.75 bar there. And then this is on imaging, you see here, the nodule has been there near the OCT catheter, and it has burnt the nodule. And this is the actual OCT run there. So it is bare, and this is the cleanly shaven area. And then it has very well yielded. It was there in a very bent area, very tight, significant nodule like calcium there, which was treated with a bigger bar there. And coming to another way of treating a calcific nodule, what I have done is, in this angio, you see a severely calcified vessel. I've dilated with a NC. I did a OCT. You just concentrate on this white part. This is the cross-section where you are getting. See, in the angio co-registration, at this point, we have this calcium here. And then you just come up to the next point here, and then this is the thickness of calcium. And you come here near that diagonal. This is a spot, there is a protrusion. There is a calcific nodule. So usually this is what happens. And when you do an imaging, you can clearly pinpoint and you can put a marker in your angio co-registration where what is present, what is the thickness of calcium, where is the nodule. And then what I have done is, I know what is where in this imaging, and I have done an IVL there. Usually what I do is at the calcific nodule, I would like to give more shocks, like probably some 20 shocks. And then many times we try to repeat the imaging before you do. And if there is any doubt, you can again take another IVL, or take if some shocks are left, you can again deliver the that nodule or spot there. So this is after that, with satisfactory image, I have just stented, and with excellent expansion. Look at the place of nodule. What happens is, although I have done IVL post-dilated with OPN balloon, this is what I got here. There was a reasonable stent area, although asymmetrical stent expansion, and some amount of nodular yield was there, although it was not an excellent elliptical stent expansion which we get. So this was the final angiographic excellent expansion of the stent there. And recently I came across a paper, very interesting, ostial left circumflex lesion with calcific nodule treated with laser and atherectomy and only drug-eluting balloon. So very interesting paper, but anyhow, I still don't have an experience with Excimer, like people like Ashok or like Kirti who is here can throw some light on this. And to conclude, perfect management is still controversial. All these options like orbital, Excimer, laser, rota, IVL, and high pressure balloon are still there. And we are only left with rota, IVL, and probably now laser. And I think treatment still has to evolve regarding calcific nodule. Thank you very much.
Want to ask the panelists?
Sir, you are muted.
Yeah, if you want to ask
Ashok, sir, you are muted.
I think I'm okay now. Can you hear me now?
He's okay, sir. He's okay.
Sir, he's okay,
sir. I thought the panelists could actually contribute. Pratap, I was just saying that to you. That maybe panelists, there's Arun Kaushik, there's Tanuj Bhatia, there's Rupali Khanna. Can they contribute something to the discussion? I mean, we have a lot to say and a lot to comment, of course, from, I'm sure Kirti would talk about that in his. So Rupali, you have any comments on calcified nodules and your experience with that? But this was a great talk.
Yeah.
You covered it well, Salamani. Those were great cases. You covered it very well. But Rupali, over to you.
Thank you, sir. First, congratulations. This was a great talk. I think sir covered each and every modality. So with my experience, we have used IVL in few cases of calcified nodules, and we have seen good crack in that. But yeah, the expansion is definitely eccentric. The nodule, which part is little bulging, still we don't get a very concentric type of expansion in these cases. But my question is that these nodules, usually when they have, the lumen is usually big in these cases. So rota, in all cases, I think will become a little difficult because the minimal luminal area near the calcified nodules, sometimes it's okay. So either we are left with only with IVL options in our cases. What's the opinion of panelists or experts?
I'm just going to briefly comment on that because he showed it, Selvamani. When you image, remember where your wire is in relationship to the nodule. That is a must. And if you actually know that it is close to that, your rotational atherectomy will give you an ablation of the nodule. If you ablate the nodule and use IVL, then you're going to be closer to that calcified. You partially ablated it, and therefore you're going to have a better efficacy. But if you, and I'll show you this tomorrow, that if you give enough pulses, you'll create fractures on the side of the nodules and not necessarily in the nodule. You'll never create fractures in the nodule, but you'll create them at the side of the nodule. What that does is can give you a circumferential expansion rather than elliptical expansion because you're going to be able to press the nodule back. So that is what I have to tell you about all this. So therefore, I would actually rotablate those heavily calcified lesions anyway, and then image it and then understand what is happening. Because when you think of when you see those vessels which are diffusely calcified with eccentric calcification, there's going to be multiple areas of nodules. Do it anyway. You think rotational atherectomy and we don't have orbital, think rotational atherectomy, do it. Then you start analyzing what to do next. There's no point doing anything prior to rotational atherectomy.
Sir, do you think that 1.75 bar instead of 1.5 will make a difference or not?
Wow, Pratap, you raised exactly what I was thinking. You see, when you have heavily eccentric lesions, I'm not saying go with a 1.25, but step up your burr. It's far better because you're actually going to have a better ablation. You're actually going to have less of debris going down. And you actually, on occasions, you may rotablate for literally 3 or 4 minutes in trying to get that across that calcified nodule because of guide wire biases. So I'm very happy to actually go up, and I would go up with a 1.5. I may follow it up with a 2 because after 1.5, I'll image and may go up to a 2 because then it would be very good to do a 2. So maybe 1.75 is too aggressive to start off in a diffusely heavily calcified eccentric lesion.
Sir, if
Yes.
nothing works, how would you conclude the case?
What do you mean nothing works?
You have not been able
You
to
find nothing works.
the nodule is still there just as it was
No,
to begin with.
remember, safety of the patient is a must. You start going up on pressures, and you after that, after a particular point, you look at the MSC. You don't look at the eccentricity. You look at the so you will have eccentricity. You look at MSCs. That's what I wanted to comment on that. You actually have a fine balance. I do go up with OPNs. Tomorrow you'll see how much I use OPNs for. And then you need to know when to stop on that, because you're going to rupture those vessels if you just be very aggressive with this calcified.
Thank you, sir.
So you go by MSAs, and you know it and yourselves anyway. Anything more than 4.5 theoretically is supposed to be good. You get to 5.5, you just forget it. After that, you're not out there to. It's not a battle between the calcium nodule and yourself.
So can we go to the next
and sir, sometimes if on
let's move forward. Pratap, can you ask the next presenter to go ahead for?
Yeah, please. Dr. Kirti, Kirti will be talking about IVUS in calcium. Kirti, please.
Hi, good evening, and thank you again for this. I'm going to share my slides. Can everybody see them?
Yes, Kirti, yes. We can see.
Great. First of all, thanks Ashok, thanks Vijay, everyone for inviting me on this podium. And I'm going to try and run through, because I know you guys are running late a little bit, but let's go on to the cases. The basic questions we all ask in calcified lesions is, one, what does the CT show? How much is the calcium distribution? That's a very important thing. Then, does my imaging catheter track? I think that's the first question. If the answer is no, you need to know whether your microcatheter tracks. And if your microcatheter does not, then you have two options in our country. One is Tornus and the other is ELCA. And sometimes, even after doing a Tornus and an ELCA, you still have to use the second layer of devices like balloons and rotational atherectomy. Now, this is a case where we had a CTO, and once we crossed the CTO, you realize that we have no microcatheter going across, a 1O balloon not going across, struggling, a guide catheter backing off. Here is the time to put off your ELCA, and once you have your ELCA, you establish 4, you go now into your imaging tools. And what imaging tells you, and IVUS tells you amazingly, is that your distal lesion, which is in the distal LAD, is without any major calcium, and it got great landing zones. It's 18 millimeters long. It tells you 2.5 millimeter stent is going to be fine. But when you come into the proximal lesion, you know that the landing zones are fine. You know the size is okay. You need to know that it's going to be like almost close to 40 millimeters of stent that you got to go from the left main into that mid LAD segment. What is important is the longitudinal views help you decide and determine that this proximal LAD is going to be rather tough to crack. And you might have to do a lot of work before you kind of get your stents into it. And everybody who tells me that that IVUS is difficult to kind of tell you length of lesion and length of calcium, I think it's not true. It gives you a fair idea of where the calcium is, and it gives you a fair idea of where you are going to face nasty calcium in terms of preparing the lesion. Now, once I know that, I know we look at this segment closely, and I know that I'll have a 4O going in there, a 4O stent. That's my target lesion there. And then I got to follow it up with a 3.5. So I already know with my IVUS that I need to have my target is 4O, my left main is 5O, and my LAD is going to taper down to a 3.5, which is good, and probably even less over here. Now, once I do that, and the distal is 2.5 by 18, of course, once I also know that once I've done my laser, I can see the initial cracks. And then you look for, I go to an NC balloon, and if the NC balloon doesn't show expansion, I would quickly go on to an IVL balloon at the area where I see in expansion. Now, the IVL is opened up well, so that tells me that I look at my IVUSs again. And what is interesting to know is that your IVUS shows definite cracks. You can see the crack here, which is actually worsened here. And so you deepen the crack, you widen the gaps, same here in this proximal lesion. This is kind of worse. This is that you actually dilated it further, you crack that deeper. And this is, you don't really need to demonstrate the gaps or the cracks at all, as long as you've seen a complete expansion of your balloon, I think it doesn't matter at all. So here we are, we've completed the case, we've achieved our MSAs, and Ibis has told me that it was okay to kind of do that. Uncrossable lesions, it's a great way to kind of have strategies of the various devices. And what it has told me is that no single device is going to work on its own, and you need a combination of devices on most times. Now, when you have your imaging catheter track, that's a great thing because you know that your lumen has no issue of an axis. But if it doesn't, you can exchange for sometimes you can exchange for a rota wire, and if your Ibis catheter does not go, like it doesn't want to go in over here, exchange for a rota wire, get your rotational atherectomy, and then you can choose a tool of your choice and go on with your case. Sometimes it is impossible to even non-lesions without fluoroscopy, fluoroscopic calcium. Here we're going at 20 atmospheres and you don't dilate them. It's okay to pull out your rotational atherectomy bird. So the axis lesions like excimer laser, rotational atherectomy, the tornus, don't require imaging to guide you. I think it's a physical inability to cross or expand that guides you into choosing those devices. Now, once we are able to get the first access going in, now you've got to review your images, whatever your choice be. And I think here is a choice. You have a severely calcified lesion. Of course, you know that you require rotational atherectomy. So you start with a 1.5 burr. You know that at this point in the distal segment, just beyond the diagonal branch, your burr took the longest time to cross this lesion, and you've got to be patient. This lesion was approximately around 7 minutes of rotational atherectomy time, which takes around an hour to do. And when you do that, you realize that right there, all your Y bars, something that Ashok has been talking about, and all of us have been talking about. I saw Selvamani talk about it, the favorable wire bias on a protruding calcium. There's no calcium on the opposite end. There is a protruding calcium mountain going into the lumen, and your wire is nestled right in that with a 1.5 having made a cut. Same here. And you want to see these reverberations tell you that this is a lot of deep calcium there. It also tells you that the diagonal branch has something nasty happening at its ostium. So dilating over here would mean closure of that diagonal branch. Based on this, I know that I'm going to escalate my burr. So I go up to a 1.75. And if I had an 8 French catheter and a 2.0 burr on my shelf, I wouldn't hesitate to go to a 2.0 burr. This is what I get post 1.75 burr. Now it's important. I open up that diagonal branch, which is very, very important, place my first stent, go through the struts. And the strategies are simple. Follow it up with a 4.0 stent proximally, a 2.5 stent, marry the two with a good dilatation in the center. And I've got my MSAs, which are completely what I wanted. They're right in the target zone for all those areas. This is a case which is a left main bifurcation, heavily calcified in the realms of an acute coronary syndrome, an ST elevation, myocardial infarction, left ventricular diastolic pressure is 18. I think in calcified lesions, especially when they're in the left main crossing, hemodynamics are uttermost important. Whatever device you use, hemodynamics are important because you could quickly crash the patient in this. Now here we put in an Ibis catheter, but the Ibis catheter only goes this far. And when this Ibis catheter goes only this far, all you know is that you have a very calcified lesion, which is going to show concentric calcium all through this distal part of the artery that is mid-LAD. And as you come to the ostium, again, there's this scattered calcium, there's a mixed plaque around. And how do you choose your device? Here, we were not able to cross the imaging catheter into the circumflex at all. And therefore, if you look at these images closely, for us, it was no brainer. Even if it's an acute coronary syndrome, it's a rotational atherectomy. A 1.5 burr into the LAD, followed by a 1.5 burr into the circumflex. And often enough, you will see that in these right angle circumflexes, post-rota, you'll find this neolumen. Does it really bother me? It used to at some point in time, not anymore, because I think this is very favorable. I always almost know that in neolumens, my dilatations are going to happen at very low pressures. I wouldn't have to go to really, really high pressures because that's the most serious crack in the calcium that you could have made. Now, this is the circumflex artery, and you can see that the circumflex artery looks, again, very severely calcified. So my question is, just because we see circular calcium right here, the depth is not something that I know. It could be either thick or thin. It doesn't matter. Do I need to make a choice based on this about my next device? Probably not, but what it tells me is that in this area, if I'm going to have an expansion, then IVL is going to be my next choice. But first, I have to find out if my NC balloon after rotational atherectomy is going to crack it at all. So in this patient, based on this, now what do we have on the IVUS? We have a large left main. We have a landing zone in the circumflex 32 millimeters downstream with eccentric calcium proximally and concentric a little bit further down. And the IVUS only went 14.7 millimeters into the LAD with a more than 180 degrees of calcium in this LAD. Downstream, the landing zone still has to be identified. Now, when you have this kind of calcium cutting you, what do we choose? Do we choose devices based on calcium? No, I have a very simple approach. I just decide the size. Distally, I needed a 2.5 NC, so I went up and it looks like it has expanded the lesion well in two views. In the circumflex proximally and the LAD proximally, I took a 3.0, and then in the ostal lesions, I took a 4.0. All these balloons are very well dilated, fully expanded. I don't need another tool. I've already achieved what I wanted to achieve. My next job is to go and place the stents. So based on stents, once we've done that, here is the final ostium, and I think I've got a good 6.8 at the ostium, the MSAs of 8.5 coming down. And I think these kind of patients do well once you've expanded those stents, made sure that it's fully expanded. You've got an optimal expansion. Not only that, but you made sure that the residual plaque burdens are low. That means you appropriately sized the stent for the segment concerned. What happens when you have calcium along with thrombus on this? Very, very eloquent little bifurcation. Of course, for me, technical complications don't need to happen in the cath lab. We have a variety of options available. For me, this was a case where I used an excimer laser. And the IVUS showed me that there's eccentric calcium in the distal left main, which is difficult to treat. Rather, whatever technology, we really are inadequate in treating these. We have layers of opposing calcium. And again, the next story goes, if I do an NC balloon, which is my next automatic thing, is that you see in expansion at 18 atmospheres. And that defines that you need to choose your IVL here now to see whether you're going to crack it. It cracks well. And of course, you can get a great result. The stent is just a follow-up after you've prepared your lesion. A case from 2011, very early on, we realized that after rotational atherectomy, when we used a flextome at high pressure balloons, dilatations, we were able to see cracks in these calcium. And this is from around 10 years ago that we recognized that fracturing these rings of calcium was of utmost importance to be able to get MSAs like, so early experience, cut and stent was good. Rota cut and stent was good. Importance of fracturing was established. Later on, when we did this circumflex, which I've shown many times, we realized that we could have we tried to do this with a very simple strategy of flextome and a 4.0 balloon. This is what we got. We had an ISR in 8 months. We had to do a rotational atherectomy. So what did it tell me? The cross-sectional, the MSA was not adequate with this technology. It was great with the rotational atherectomy. Conclusion, in calcified lesions, flextome cannot replace rotablator just because it reaches there. Sometimes you have to debulk. This has actually led us to a strategy where in left mains with severe calcification, it's a great idea to go up and step up the burr, which we did, and then follow up with flextomes, which go up to high pressure. And we are able to get our MSAs in the target. And IVUS actually brought us to that point where we could recognize how to choose our devices when we get into trouble. But the simple algorithm of an aggressive rota cut, that means stepping up from 1.5 to 1.75, often works along with other balloons, with flextomes or other NC balloons for dilatation. And that's a great strategy. Now, here is a case which is a left main, and you can see that this is these calcified nodules of protruding calcium which happen in this severe left main. Here, absolutely taken care of by rotational atherectomy, higher sized burr size, followed by flextomes which are sized to the balloon. Side arm is a little smaller flextome. The main artery is the 3.5. Sometimes you can go to a 4.0. But what is important is that these lesions then get completely opened up. And what happens is when you have different types of IVUS images, protruding small nodule, of course, you can dilate it. MSAs are great. You'll see a little bit of malapposition. Don't worry about it, as Ashok had mentioned. When it is less than 180, upsize the rota when the wire is very close to it. But even if it is eccentric, don't expect a circular lesion. You will find a D-shaped stent, which is often enough okay if the MSA is fine. Then protruding calcium, when you upsize the rotor bore and you do a flextome and you do high pressure balloon dilatation, the protruding calcium often enough will leave that MSA, that malopposed area. That's fine. But in these semi-calcified lesions, you need to use a flextome, and if it doesn't work, or an NC balloon, and if it doesn't work, quickly go to an IVL because it'll crack the lesions and you can expand it well. Opposing plates of calcium are difficult to treat. In these patients, IVLs do beautifully, and that is almost my first choice now, especially in the left main region or the ostial LAD, and it cracks. It makes my case much simpler. HD IVUS works well. Blood clearance is not a must as in other technologies. LV dysfunction and renal dysfunction are a big player where HD IVUS is my first choice. Do I miss identifying calcium thickness? Absolutely not, because I think the strategies are simple. Advantage is multi-vessel and multiple runs with IVUS do not cost me any more contrast. LV, and of course I've mentioned it. We have these layers of access devices, which are your first devices. And then you get on to your layered approach where you upsize the burr with wire bias, or you go to, after the excimer laser or tornus, you may come to a rotablator. But once you've done that, you need to image. And once you image, then you can decide whether you want to use, my default strategy is an NC balloon based on the size. And the way that behaves, then I reflect back to my imaging to see that in my OPNs I reserve for the ISR, scoring balloons, flextomes. I've not used scoring balloons, but flextomes and Wolverines, very, very common, eccentric lesions and ostial locations for ISRs too, and IVL shock wave for concentric calcium, opposing plates of calcium. And thank you very much, and I'll be happy to take questions.
Kirti, it was a great talk. Actually, I just wanted to ask you that when the wire bias is wire is away from the calcified nodule. So again, what will be your choice? If the rotablation is actually to be done and the wire bias actually in the calcified nodule, the wire is away from the calcified nodule.
If the wire is away from a calcified, see, what you've got to remember is that that alone does not decide your strategy at one level. Because when you're looking at calcified lesions, what you look at is the entire different artery. In the same artery, you'll have a calcified nodule 5 millimeters in it, and then you'll have concentric calcium ray stream down. So the first device that you use, the imaging is not going to decide your first device, and often enough, rotational atherectomy is not decided based on imaging. Rotational atherectomy is an access tool, and so before you can get your imaging catheters there, you need to do rotational atherectomy most of the times in calcified lesions. So the question is, after you've done the 1.5 burr, then you do imaging. The only thing that imaging decides and helps you is whether you need to upsize the burr for the area which took the maximum runt of your calcified lesion. That means if a rotablator engaged a particular point to the maximum time, then that's the point you need to see whether 1.75 is going to make a difference or not. Imaging is going to tell you that, the favorable wire bias. Now let us assume that there are areas which are unfavorable wire bias and you've got a little protruding calcium. I think then you need to go with your NC balloon and see if it'll expand. And if it doesn't expand, then as Ashok said, that you need to identify the size of the stent that you're going to put in there and say, it's very eccentric. For me, I undersize the stent. So even if it is a 3.5, I'll go to a 3.0. Take an OPN 3.0 and go gently. Don't go crazy pressures, but you can go up to 25, go up to 30, go up to 35. But I wouldn't ever go beyond 30 or 35. And if it doesn't yield, then I think that in those areas, if you think you're not going to get a great MSA, drug-eluting balloons are fine. But putting in a stent over there, which is completely unexpanded, is going to be a difficult situation. But remember, if you can get a 1.75 burr into an artery, that means you've got an artery which has already got a lumen of 2. To make a lumen of 2 into lumen of 3, a calcified nodule is not going to hurt you. The problem is it may not get you to a 4. So even if you get a reasonable MSA, I think you're okay. But choices of device will have to depend upon the overall worst calcium and not one spot of calcium.
Yeah, any comments from the other panelists, please? Because the time, it is 9:25. Any comments?
Let's move forward for the next talk, please.
We will go to the last talk. Actually, Dr. Balbir will be talking about OCT will be preferred for all the calcified lesions by him.
Yeah, thank you, Dr. Pratap. And we just heard a presentation on how good is IVUS for as an imaging. Let's look at a comparison between the two. We have briefly seen a lot of slides being shown. We have imaging now. We accept that imaging is important in a calcified lesion. Let's look at prognostic implications of calcium and treatment by PCI. So this is a follow-up of 3 years. So you see that the MACE rates are almost double, including death, MI, and any revascularization. So it's almost double, 23 versus 11% at 3 years. So this is a not too old study, 2014, and a pooled analysis of 7 contemporary drug-eluting stent studies. So this is the impact of calcium. However, if you go to Gary's paper on ADAPT DES IVUS sub-study, you see degree of calcium, low, intermediate, high, had no impact on major adverse events. Death, MI were almost similar. Stent thrombosis, almost similar, whatever be the degree of calcium. So what has changed? So what has changed is that in the ADAPT DES, there was more complex cases. Lesion morphology was more complex. They were but treated more aggressively with optimized stent expansion. So both IVUS and OCT players would accept that doing a stent optimization in a calcified lesion is the goal. And you can actually get MACE rates almost similar in low to high groups. Now, coronary angiography is very insensitive for coronary calcium. You can clearly see this is original paper from, again, 1996. There was no calcium seen angiographically. And you see a calcium arc on intravascular ultrasound. So coronary angiography is not the method of choice for assessing the coronary calcium. This is again Gary Mint's paper, 1995. I will study, see a total gap between angiographically determined calcium and imagingly determined calcium. So-called innocent-looking lesions could also become heavily calcific. So first thing is, how do we use intravascular ultrasound to assess imaging? So we understand it is sensitive whether we use IVUS or OCT, but what are the differences? So let's look at histopathology and an IVUS study. So this is an IVUS. It shows you the arc of calcium, but it can't penetrate into it, so you don't know how deep this is going to be. It may be just looking very innocuous, that this arc is about 60-degree arc, but you may say this is innocuous. But the same thing on OCT, maybe thick calcium, and this can make a difference in a particular patient. So you see that in this, you know calcium depth is going to be assessed. Now, OCT can measure calcium thickness, area, and volume, which IVUS cannot do. Now, if you look at the IVUS assessment, you need to know the arc and the length to actually quantify what is likely to be the degree of calcium. Then you can also classify as superficial and deep based on where it is located. Again, it matters clinically. But the problem comes after you've done a technique. For example, this is an IVUS image pre. It's 360-degree arc, and we realize this should need a ablation. So atherectomy has been done. After atherectomy, you see the reverberations. Now, do these reverberations are equivalent to a crack? Do these reverberations mean the job has been done? Or we are still unsure and we want to upsize the burr? Or now we want to assess a balloon to tell us that whether the expansion is going to be adequate. So these questions still remain after an IVUS and rotational atherectomy. However, a thick calcium, an orbital atherectomy has been performed, and you can see the degree of calcium has been reduced. So this image, over this image, helps you to guide the next procedure. What about calcified nodule? So this is an angioscopic image of a nodule. This is how it looks. And if you look at how IVUS and OCT fare in a calcified nodule, you clearly see that you're still having some guesswork. Why is this guesswork? Because you don't see behind this calcium. So you guess that this is possibly going to be the nodule. However, you're very sure on OCT that this is a calcified nodule because your approach can differ. Let's look at this example. Innocuous looking distal RCA, not too tight, but he came with the top positive chest pain. This was the lesion. It looked very innocuous. So I went ahead trying a balloon on this, and the balloon inflation, 2.5 crossed, but was not fully inflated. You put in a IVUS to see what's happening, and you see a thick calcium, concentric 360-degree arc. So this was the balloon, 2.5, not fully inflated. Got a cutting balloon, and angiographically, no calcium seen. And on OCT, see there's no calcium, and see this OCT. So even innocuous looking angiographic picture can sometimes come out with surprises. But a vigilant operator may not have used imaging, but would be pick up these small clues to get into a better outcome. So this was a 10 millimeter cutting balloon. Now this is the OCT image, which is very important to see. This is the cutting balloon of the same image that I showed you. So just see this image. This is the image. This is the image. And this is after a 3 millimeter cutting balloon, 3 into 10. You see the cracks. This cracks tells you that you can confidently now get into the stent. Now these cracks, mind you, are not very well seen on intravascular ultrasound. I won't say they're not seen, but they are not as well seen on. And see the imaging after the stent, an MLA of 8.27 in the distal part of RCA. So stent expansion is good. We all understand it. Bigger the better. This has already been discussed. Let's look at another example of a 66-year-old lady with angina. This is heavy calcium on angiography. And so balloon preparation before an OCT comes in. And this is the OCT, which will show you the degree of calcium is huge. This is nodule, a 360-degree arc of calcium all around. So you see length is entire range is calcified. So how do you proceed without imaging or without OCT in such cases? So the analysis is clear. You have the landing zones, you have the diameters, you have the degree of calcium, you have the calcified nodule to deal with. All this becomes simpler when you manage this and you use an IVL and see the cuts with IVL. You see the cut here, you see the cut here. It helps you to guide that you've done whatever best you could do. This is the IVL in this particular patient. Helps you to guide. And after this, you see the cuts. These are the cuts which are clearly seen. And a stent is placed. 2 stents were placed. And this is after 2 stents. Now, despite best efforts, using 4 and then 4.5 millimeter balloons, angiographically looks elegant and excellent, but you see the expansion is still not as good as what you would have wanted at this particular point. Come what may, this area had the huge calcium, and you will end up, but the patient did very well. The patient is now more than a year of follow-up. So now, finally going to this slide. So you have IVUS versus OCT. You want this image or you want this image is the question. Of course, contrast usage and of course, the LV function do matter with OCT and IVUS, but RCA can be now managed with saline injections much better than we ever thought. And contrast is, we rarely use contrast for the right conveyor. And calcified nodule has been discussed. I will not go into it. But going to a calcified nodule, OCT is clearly better than what we thought. And I would end here not sharing anything more about calcified nodule, but with this case, again, a stent failure, the proximal part of LAD, Austin part, age 88, ugly lesions, and LV dysfunction. And this is the OCT examination after the scoring balloon. So this kind of lesion, and you know the bifurcation, calcium, but OCT can give you a 3D management of a bifurcation, which IVUS cannot give. Does it really matter to have these beautiful 3D images to guide? It does matter. You know where the wire is going. You know how the struts have opened. You know whether there is still overhanging link to carina over the struts. This makes a difference, at least in some of the Japanese bifurcation club studies, that these also make a difference. Thank you very much for your patient hearing.
Thank you very much, Balbir. I think summed it up extremely well. That was the last presentation. I think we are running to 30 minutes over time, and I think that we're not going to. Wasn't this the last talk, Rajesh?
Yes, it was the last talk of the session.
So we should move to the next session. But I would just say that one aspect I would want to convey to the audience. I don't want you to go out there and believe that every calcified lesion, you don't know what to do unless you start doing imaging. Sometimes you end up a session believing that if you didn't have imaging, you don't know what to do the next step. But I want to make you understand that if you have the complex, real world, heavily calcified lesions, you can't do without it. And it's not just the strategies. I mean, theoretically, I would rotablate and IVL. Anything less than 3 millimeters, I would rotablate. Anything more than 3 millimeters, I would IVL, rotablate, and IVL. It's actually the safety of the patient. It's giving him the optimal result. It's actually so actually what you end up in has to be a patient who's not got a perforated vessel and yet has had optimal expansion. You give him that, you've got him off the table, and it's only imaging which allows you to. With that, I leave you to think where you want to use imaging in your own practice. Okay, with that, I just over to the next session.
So thanks, the chairperson, panelists, and all the speakers. Let's move to the last session. This is regarding the big debate on functional assessment of the coronary lesion. And let me invite chairperson Dr. Bahulian, Dr. V.T. Shah, Dr. Nishav, and Dr. Tarmabo to chair the session, and the panelists are going to be Dr. Bhupender Sihag, Dr. Anupam Bhamri, Dr. Ranjan Modi, Dr. R.R. Mantri, Dr. Ankur Gupta, Dr. Sudarshan Vijay, and Dr. Ankur Ahuja. As we are getting delayed, let me invite the talk first to be followed by Live Keys demonstration. So first of all, let me ask Dr. Justin Davis. Is he there? Dr. Justin, Dr. Shah, please.
So Dr. Justin said he'll join us soon, sir.
Yeah, okay. So maybe then we can have Dr. Neil Johnson's lecture first.
Yes, so we reverse the order then? All right.
Yeah. We always give preference to you, Neil.
No. Thank you so much, VT. It's a pleasure to be here. Can everyone see and hear me? This is working out okay?
Yeah, this is working out okay.
Okay, thank you so much for the invitation. It's a pleasure for me to join you on your Friday evening. My Friday is just getting started. I'm on call this weekend, so it should be a fun time for everybody. I'm going to be talking about, our options, and I would say that I've put them into two categories. One category are the gatekeepers that we use to get patients into the cath lab, right? Who needs invasive angiography? The second question is, when we are in the cath lab and we have the angiogram, how should we maybe make our decision? Should we just use our eyeball to tell us? Should we make some kind of measurement with wires? Should we be using angiographic simulations like QFR? Should we be falling back on what the spec told us? Or should we be looking at more advanced tools like MRI and PET? And what I wanted to do is to not be so dogmatic, black-white. I want to go through some data, especially some stuff that's come out in the last couple of years, and think about options, because not every hospital has every tool, and that's very clear. And so I want to think about some of the trade-offs that we've seen from emerging data. And let's think a little bit first about comparing cardiac MRI to FFR. There's a fascinating trial that came out now 2 years ago called MR Inform, Mr. Inform, looking at a strategy for patients where they went to the cath lab, did FFRs and everything, used that to make their clinical decisions, or used a non-invasive MRI scan, and only when it was positive went to the cath lab, and then only treated the areas that were identified on the cardiac MRI scan. What you see is that that kind of strategy reduces the amount of revascularization, 36% versus 45%, but has no difference then in clinical outcomes, be it for angina or for composite MACE up top, suggesting then that actually a lot of this with very sophisticated imaging like cardiac MRI or PET can be done non-invasively. There's some emerging data I'd like to talk about using QFR or other tools like that, angiographic-based FFR. In fact, if you keep your eyes on this spot here, in about 1 month time at TCT, we're going to have the results from Ffr 3 China, which is a large randomized trial looking at QFR being superior to angiographic guidance for classic 1-year MACE. And then there's a non-inferior trial going on in Europe and Japan, again, quite large, 2,000 patients, looking to ask the question, is QFR non-inferior to MACE? So different strategies comparing QFR against visual assessment or against invasive wire-based physiology. What's interesting as well is to compare some of these wire-based angiography strategies against non-hyperemic pressure ratios. And of course, they're trade-off both ways, right? You know, with angiographic FFR, we avoid the pressure wire, but simulate hyperemia. And so that requires some special software and then is an indirect computation of pressures, where of course, the non-hyperemic pressure ratios need a pressure wire, but they do measure the hemodynamics directly and avoid hyperemic drugs. And so this is a bit of a trade-off. And what's been very clear, both from looking at something like FFR angio, which is, you can see the example up top, this right coronary artery, where all of the non-hyperemic pressure ratios get it wrong, but FFR angio gets it right, or a systematic work down at the bottom looking at QFR versus IFR for a reference standard of FFR. You can see that actually angiographic FFR beats non-hyperemic pressure ratios. So if your goal is to move away and make things simpler, what I found fascinating about this data is that if you're going to skip hyperemia, maybe you should just skip the pressure wire as well and move to some of these angiographic FFR tools. And as I mentioned, the clinical data for supporting that is something that's emerging then through the Ffr 3 program that should be coming along in the next period of time. What about FFR against visual percent diameter stenosis? Of course, everyone always talks about the FAME trial, but what I want to do is to talk briefly about a recent trial called Flower MI, which was largely the same kind of strategy. This time looking at non-culprit lesions that were found at the time of STEMI. There had to be at least a 50% diameter stenosis, and they said, all right, what if you just stent them all versus using an FFR guided strategy? Had just over 1,000 patients with a composite outcome, as you can see there. And overall, no significant difference then in a composite of death, MI, or urgent PCI. What's fascinating, though, is to look into a bit of the details, and you'll see that when operators have FFR at their disposal, they select more lesions, right? 980 versus 891. Operators are more willing to, instead of just stent lesions, to pick it out for physiologic evaluation. As we've seen from all the other trials, when you use physiology, you do less PCI. It's only the lesions that need to be done, 38% less PCI with FFR. Although interestingly, in this case, there was still a fair amount, 16% of PCI that was done in the FFR guided arm without FFR itself. Despite putting in 40% fewer stents, there was no penalty in angina or quality of life. You can see the various metrics in this table, be it anti-anginal medications or this quality of life score or CCS angina class. And despite the fact that there was less PCI, there's no difference in death, MI, late revascularization, or their composite. So actually, I would turn this around and say that you can easily reduce the amount of PCI by 40% without impacting clinical outcomes in a meaningful way. Of course, you have to buy a pressure wire for it, so everything does come with some cost. Let's think a little bit about what was the topic of this debate. Again, I'm not trying to be dogmatic. I'm just trying to compare various choices we have among tools to help us revascularize patients. Well, the challenge of non-hyperemic pressure ratios is a concept that our bodies have called autoregulation. What autoregulation means is regardless of our blood pressure, under resting conditions, flow is kept about the same. So if you stood up and your blood pressure went down a little bit, of course, blood flow will drop slightly, but what your body does a moment or two later is compensates for that and brings coronary flow back up. Or let's say your blood pressure goes up, you're in a very stressful situation. Of course, your blood flow will increase for a moment in time, but it will then back itself back down to where it was in the steady state. And you can see both the concept on the left here, as well as some of the experimental data on the right, really looking at really between 40 millimeters of mercury and 120, 140, somewhere in there, there's a broad range of coronary autoregulation where flow is stable. And what this means then is unless your coronary pressures are outside of that range, and of course we're worried about low coronary pressures, that's what happens with coronary stenosis, unless your coronary pressures are below 40, which I must say happens uncommonly in the cath lab, measurements of resting flow, resting resistance, and resting coronary pressures cannot exclude or diagnose patients with any degree of certainty because of this notion of autoregulation. Now, of course, there may be large group associations. I don't want to deny that. But of course, we treat one patient at a time. And in that individual patient, those measurements simply don't give you insight into the mechanisms of symptoms or what's going on because autoregulation prevents us from doing so. That's the whole reason that we do stress assessments in cardiology, right? We stress the electrical system, we stress the coronaries, we stress the valves, right? It's a stress specialty. And the reason why is that when patients are out there in the real world and they walk or do stairs or whatever, and they have chest symptoms, we would like to understand what the hemodynamics are at that moment. But by the time the patient sat down and feels quite comfortable in our clinic or the emergency department or is sedated on the cath lab, that's the moment when the patient doesn't have any symptoms. And so to make an assessment at that moment and yet try to predict what's happening under stress conditions is a bit of an internal contradiction. And that's the reason, of course, that we do stress testing. Well, all right, you say, if this is such an important effect, why was this not seen in these two randomized trials that came out many years ago, looking and claiming that it was non-inferior to use non-hyperemic pressure ratios? And the challenge here is that not all trials are built the same. And this is a fantastic reminder that if you're doing a superiority trial, you really need to be conscious of every design decision because you're penalized if you're a little bit sloppy. But non-inferiority trials are exactly the opposite. They reward the careless. And so the less rigorously conducted the trial, the easier it can be to show non-inferiority. And I want to walk through some of those implications now. So if you're comparing non-hyperemic pressure ratios and FFRs, you can kind of think of it in 4 quadrants, right? In 2 of them, either both of them are negative, in which case either way you wouldn't revascularize. On the other hand, both of them can be positive, in which case you'd revascularize. And that actually happens for about 80% of lesions, as we'll see. But what about the disagreements? That's where it's most important to understand which one is pointing us in the right direction. When the non-hyperemic pressure ratio is negative, you'd say, well, medical therapy, but the FFR is positive. All right, what should we do? And then, of course, the flip side happens for the other example. As I mentioned, about 80% of the time, FFR and non-hyperemic pressures agree with each other. And what that means is even if you have a huge trial, or at least it sounds to you just, 2,000 patients, 2,000 lesions, it's just an enormous trial, realize that that boils down then to only 400 lesions where there was a disagreement between these 2 of them. And those 20% get mixed out, get diluted with the other 80%. Again, a advantage if you're running a non-inferiority trial because this carelessness, this sloppiness tends to make the 2 groups look more similar, but not good if you're trying to run a superiority trial. The other challenge for this trials is that they did physiology in a small majority of patients. You can see this is data from the trial that was conducted in Scandinavia. And if you go through the table and figure out how many stents were put in and this kind of stuff, you'll realize that only about 54% of revascularization was based on an FFR assessment. And the reason why is that they permitted angiographically significant stenoses to undergo PCI without physiology. So were they physiology trials? Well, I guess just barely, right? They just got over 50%, but it's not like other trials like FAME and such where 90% or so of revascularization decisions were based on FFR. So again, this dilutes it out. If you look at causes of death, you'll see that including all-cause death adds events, but they're really events without a mechanistic relationship to physiology. Things like malignancy, infection, suicide, coronary physiology of any kind can't help out those things. So again, it dilutes out the benefits. And then finally, if you say measured physiology in the circumflex, but then a year later, a patient has an MI in the RCA, Is that really the fault of it? Well, not really. We made the measurements in one vessel, but yet the other vessel was what had the event. Again, would tend to dilute out things, making a non-inferior trial look more non-inferior, but being a disadvantage for superiority. And it's for all of these reasons that if you go back to the American appropriate use criteria and look at things, they continue to favor FFR. They say it's the reference standard, has more outcomes, and I would also argue then better designed trials than those that have been done for non-hyperemic pressure ratios. I wanted to conclude briefly by talking about another study that's come out that generated a lot of interest comparing FFRs against typical imaging. And what I mean by this is it's important to think about where we include FFR in our clinical pathway. It's one of the 5 most important things we're thinking about when we're viewing diagnostic tests. You know, we talk about diagnostic and technical accuracy. Patient outcomes, of course, are vital, and cost effectiveness. But sometimes we don't think enough about when should we include this test in our decision-making process. And should we replace it? That is, should we just get rid of one thing and use it as the other? Like, you know, we get rid of invasive venography and do venous Dopplers, right? Is it a triage test? For example, something like D-dimer, right? If it's negative, you stop. But if it's positive, then you have to go on to other testing. Or is it an add-on test? That is, you take all of the existing data and then bring in this additional test. And that's the way FFR has been studied. If you look at the major outcomes trials, the FAME trials and such, these were patients who had angina despite medical therapy. There was a large amount of non-invasive testing that was abnormal. There was an angiographic lesion that the operator felt was important. And in fact, the operators had to bring all of this data together. So required revascularization on the basis of both clinical and angiographic information. So FFR is not a replacement for clinical judgment. FFR is an augmentation. But what that means is that it's selective use of FFR. Now, what about the routine use of FFR? Let's just say we said, well, hey, let's ignore the angiogram. Let's just do FFRs in everybody. When you pool a large number of trials, and I've shown them down here in the bottom, about 60% of the time, you come to the same decision, right? So 60% of the time, if you do routine FFRs, you'd end up treating the patient in the same way. About 20% of the time, you end up what I call downgrading treatment, right? Thought you needed PCI, you did an FFR, it was negative, you ended up on medical therapy. But what hasn't been well established or tested is this notion of upgrading. Hey, I think that lesion needs medical therapy. Oh, I did an FFR, it was 7.7. Ooh, should I do PCI? Should I do bypass surgery? Never tested before in terms of upgrading our treatment decisions. This was something that was recently done in the Ripcord 2 trial. It's a trial of what I would call systematic FFR patients who were coming for evaluation, who then were either randomized to conventional assessment, largely using the angiogram, as well as non-invasive testing, or a routine systematic use of FFR for every vessel, even if it just had a 30% lesion, right? So every single vessel that you normally wouldn't touch. No change in cost, no change in quality of life over the course of this trial. And if you look at the reason why, it's because you actually didn't change management strategies, right? The amount of medical therapy was the same, the amount of PCI the same, the amount of cabbage the same, and therefore it's not surprising that costs were similar, quality of life was similar, and if you look at the components of MACE down at the bottom, it was also similar. So this is very different and argues that a routine or a systematic use of FFR is not the right way. It's not a replacement. FFR is an augmentation of clinical judgment. And so that's where I would kind of like to conclude, making an argument that I think we have a large number of choices of tools for taking our angiography and translating it into a management strategy. And I hope you'll have enjoyed some of this recent sampling of literature that's come out looking at comparisons among these tools. But the fundamental message for FFR is we need to be selective about when we use it, not routine. Thank you so much.
Well, Dr. Neil, yeah, we have Dr. Justin Davis now. So, Dr. Davis, since you were unable to join, we requested Dr. Neil Johnson to go first, and then, so now you have an advantage. You can go ahead now and counter that argument.
I'd like to say it's deliberate, but it was an error on my part. So thank you very much for the invitation. It's a pleasure as ever to be with you. And I'm sorry that I can't be here in person with you in India. but I've been asked to speak about resting indices for all. And I talk a little bit at the origins and advantage of resting physiology. But really, I think this is an argument which has been won back in 2018. And I think, it's not really a clinical discussion now. It's more of a kind of academic debate around the edges, really. So really, I think the key point here is, should we be treating all the lesions we see on the angiogram? These all look good candidates for PCI. We can all say what we would do to treat them. I think most of us could do a very good job, but really, is it right to treat them? And you may recognize these angiogram images. These are from the Orbiter study, which we led at Imperial and with Rashra Alami as the lead author of this study. But this study looked at effectively seeing if stenting in largely type A lesions, so single isolated lesions, led to an improvement in exercise capacity over placebo. And it did, but it wasn't significant, the drop. And as a result, this study was neutral, as was the Courage study, where that the difference between PCI and medical therapy was much smaller than had been expected. And of course, more recently, we've seen from the ischemia trial, a difference in the benefit from interventional therapy over conservative therapy being much smaller than one would have been expected as well. So it's interesting, in studies which essentially use the angiogram, albeit in ischemia with people coming into the study with evidence of ischemia, still the angiogram was used to identify which area to treat. The results are not optimal for supporting the use of PCI. You've seen already, and the benefits of using FFR from the FAME study. That's a big benefit, but not as big as when using IFR in the Syntex 2 study in complex multivessel disease patients. And you can clearly see using FFR to guide revascularization decision-making, implanting modern drug-eluting stents, and using IVUS optimization, and using modern drug therapies, there's a really massive difference between the Syntex 2 invasive PCI group and that of the historical control from Syntex 1. And indeed, if you compare this group with the Cabbage group from Syntex 1, they're about the same. So it shows equivalence even in complex disease patients. The FFR and the angiogram don't always agree. We know that from this study, but I'm learning more and more about this figure every single day when I look at it. I used to think it's possible that someone with a 70% lesion can have an FFR which is negative, and that's true. But what draws my attention now increasingly is the 0 to 30% cases where they have an FFR of 0.4 or 0.5 or 0.6. Now, why is that relevant in a talk about non-hyperemic indices? Well, because something's going on here. I want to know, is it that there's a high flow situation and it's just a massive error of an FFR well-known trap or pitfall? Or is it the fact actually that we're missing a lesion which is not visible on the angiogram that perhaps is being detected by physiology? I think probably the latter is a very interesting area to explore, as we see from studies such as defined PCI. Now, you know how to perform FFR, you've seen it being performed, and it's very established. IFR was first presented 10 years ago to this year. Technique we presented at TCT, which was really designed to increase adoption of physiology by simplification of the techniques, taking advantage of modern computing processing power and a greater understanding of physiology. And essentially, as you know, the phase where we make our measurements, called the wave-free period, was developed by rigorous scientific assessment using combo wire, which measures pressure and flow to detect, using wave intensity analysis, an area where the heart is neither contracting or relaxing, called the wave-free period, where we make our measurements where resistance is lowest and most stable. This is all automatic. You don't have to do any complex measurements. It's very simple and easy to use. And now you don't even need an ECG. So we know that FFR with adenosine is a problem. And we know that because one of the great masters of FFR, Morten Kern, published about it. He said, if only adenosine were not so difficult to mix, costly, time-consuming, uncomfortable for patients, and rarely potentially dangerous, it would be easier to perform and therefore would be used more often. So I thought it would just be interesting to compare some of the differences. And you can see non-hyperemic on one side, hyperemic on the other. Way, way better if they're further away from the midpoint. And as you come to closer into the middle, eventually it comes down to both of these techniques being the same. So we know with both of them, if blood pressure is low, less than 60 millimeters mercury, it's a no-go. Should not be using physiology. You can have spasm instead in the microcirculation when you expect dilatation. Ventricular tachycardia. Hopefully none of you would make these measurements in any case with someone who had VT on the table. Atrial fibrillation, we know from a large study, secondary analysis from the Ffr study presented at PCR recently, that there's no difference in outcomes, clinical outcomes, in patients who have atrial fibrillation with either the Ffr or IFR group as comparisons. Significant ectopy, well, this would appear better with the hyperemic indices, but really there's no data there. We don't have any outcome data that if someone has lots of ventricular ectopy and you average it out using FFR and use those results, that the outcomes are better. But certainly people do use that and it's easier. Adenosine non-responders, well, clearly if you're not giving adenosine, you're not worried about that. And clearly, you know, the effects of caffeine, which can be profound. And I think that if you want to talk about a mismatch between FFR and IFR, well, this is obviously one of the first places you want to look at. People drink caffeine, whether that's in India or in the United States or Europe. And you can see before caffeine, the FFR is 0.77, and after it's 0.93. So profound differences here, which can clearly lead to massive differences in the FFR result, differences in treatment, and discordance between any measures as well. What about unstable coronary artery disease? Well, the culprit artery, I wouldn't advise using physiology. You have to be very careful. You can get unreliable measurements. Non-culprit really does favor towards the IFR and non-hyperemic indices bases. We shouldn't forget the importance of blood flow here. So this is a nice case from Jan Peek's lab in Amsterdam, right coronary artery, which is treated with a stent. And then there's a LAD, which was assessed with a pressure wire. Now, the reason I show this case is that this is a long-standing difference between flow advocates and FFR advocates, and has a direct relevance to IFR and non-hyperemic resting indices. So the flow advocates have said, as you see in this case, the resting flow is low, it increases with adenosine. That looks beautiful, very normal. Indeed, in this case, the CFR is 2.8. We know if the CFR is greater than 1.7, the prognosis is fantastically good. 2.8 is amazing. Now, if we look here at the FFR, it appears that there's a significant lesion, not 0.8, but below 0.75. So we have a discordance here, not between IFR and FFR, but between blood flow and FFR. And remember, we are trying to increase blood flow down an artery, not to make it look pretty or to make an FFR value normalized. The two are different. And there was a huge amount of arguments and discussions over the past 20 or 30 years, not between IFR and FFR advocates, but between flow advocates and FFR advocates. So very big, heated discussions about this topic. And one of the beautiful things about resting indices is they tend to agree with flow. And we've seen this repeatedly in many studies. And it's very, very important to understand that this actually can make a huge difference in the interpretation of data. Perhaps this was most beautifully presented by Chris Cook in analysis, where Chris took data from over 500 patients in the IDEAL study, where they had a diseased artery and also a control artery. And the diseased artery, effectively, when the FFR and IFR was negative, had a similar coronary flow reserve to that of the unobstructed artery itself. Now, interestingly, when you look to see when the FFR and the IFR is positive, you see, let me just quit this, you see that both of them have a very, very low coronary flow reserve. Interestingly, when the IFR is positive and the FFR is negative, this is often when the coronary flow reserve is normal. So this is a false negative FFR. FFR is getting it wrong, and there's a discordance here. And the reason here is because you're unable to get enough flow across that lesion. It's still a very significant lesion, though, because blood flow is low. The group here, which often we see as well, and I, again, just question the logic here, is where the FFR is positive, the coronary flow reserve is entirely normal. It's the same as an unobstructed artery, but the IFR agrees with the flow and it's negative as well. So we have to be very careful. And I think that, the founding fathers of physiology and the debates which went on in the 80s between flow and FFR have really, come a full circle now. And the thing which is really interesting and exciting is where in the past we had to measure flow to tease out these differences. Now we're able just to measure IFR and get a very, very close match to flow, far closer than you can with FFR on its own. So valvular heart disease, be very careful. There's no data in this, both in terms of moderate, severe valvular heart disease, as is the case with congenital abnormalities or shunts. We know in the TAVI setting, there is, however, some data, again, which points towards more stability and reliability with the IFR measurements, even over PDPA and certainly over FFR. In blue, you see a measurement of flow before the TAVI valve goes in, and then red after. So after the aortic valve is relieved of its severe stenosis. And what you can clearly see is if we measure over the wave-free period, the step up in blood flow is very negligibly small, it's not significant. Whereas if you compare that to the FFR window, the average of the whole cycle, there's a big step up in flow, and you can see the FFR is significant. Now, what this means is, yet again, you probably would have missed a lesion using FFR, because there's this big suppression when the valve is still in place because the hemodynamics are unaltered. And remember, there's no data from any of the trials for using FFR or IFR in severe aortic stenosis. So be very, very careful. So hyperemic agents, remember, adenosine non-responders, non-hyperemic is better, as is recent caffeine, and anyone, of course, with severe lung disease, or if the blood pressure is already low, if you don't need to give an adenosine-related subject, you're not going to drop the blood pressure even lower. And clearly, it's more patient-friendly. What we do know from the analysis is it's cheaper to perform IFR. This is an analysis presented by Manish Patel at ACC a few years ago, showing an almost $900 saving when you compared IFR to FFR, which in a world which is increasingly cost sensitive has to be very, very important. So we've spoken a little bit about severe lesion. I'm going to spend a little bit more time showing you that in a second. But first off, let's just look at the 2-year data from Define Flare and IFR Sweetheart. Yes, this is not data from severe lesions such as in FAME and FAME2. This is data from patients that we see every day in the cath lab from 50 centers all around the world. So it's very real world data. This has got almost 100% follow-up from the SCAR registry from the IFR Sweetheart study. And you can see at 2 years, the difference between FFR and IFR is non-existent. 5-year data will be presented at TCT this year from the Sweetheart study, and I think this is going to be a very, very exciting data to look at. I'm really excited to see it myself. Similar results from Define Flare at 2 years. You can see, again, very, very limited differences, certainly nothing significant between IFR and FFR, yet again pointing towards the fact that both these techniques can be used interchangeably. And this led to guideline adoption in the ESC 1A classification for both IFR and FFR, and in Japan and in the United States as well. So I've showed you intermediate, you've seen severe. It's clearly a benefit. You can see that this is a massive prognostic advantage over the Syntax 1 study. And this is not necessarily always by just putting lots of stents in. Often it's about avoiding stenting here. And that's a major advance here in avoiding that critically, that lesion which looks like it could benefit, but in reality doesn't. Finally, I'm just going to talk a little bit about, one of the Achilles heels of FFR. It just can't measure serial lesions at all well. And, in the patients you get in India, as the patients you get in London and all around the world, there's an increasing amount of diabetes and hypertension, and being able to disentangle one lesion from another is increasingly important. This is a case Collar de Maria showed us a few years ago. You see a significant lesion at the end of the vessel, 0.74, mid-vessel, 0.91, top of the vessel, 0.98. Now, the biggest delta is between 0.91 and 0.74. So we expect if we treat it, the lesions at the distal vessel is going to increase from 0.74 to 0.91. What do we find? It actually doesn't increase after stenting, a very good result. It goes down. And this is because there's more blood flow across the top lesion, which then becomes much lower when a repeat FFR is made. So this is not a technique which is fit for the 21st century. It requires multiple runs of adenosine, often multiple pressure wires, and it just gives us inconsistent results which are variable and unreliable and don't really help us to plan. So the reasons for this are the fact that you're often having to average 3 to 5 beats, flow is low in the distal vessel, and the fact that one lesion affects the other. This was explored in the Define PCI study. This was a pilot study for the Define GPS study, which looked at almost 500 patients and found that in approximately 80% of 25% of patients who still had residual disease after what was considered optimal PCI by the operator, there was still evidence of a focal lesion which had gone untreated. Now, what's exciting is if we were able to identify that up front, we could potentially target it and maybe perhaps improve angina relief over and above what we do already with medical therapy. Now, this is a pretty revolutionary way of looking at an angiogram. We have the physiology overlaid onto it. You can see areas of severe stenosis, all calibrated in pressure units, and as is the distance measurements as well. And when you see lots of yellow dots, like at the proximal end of that LAD, you know that the IFR drop here is 25 units. If you were to treat that, it would push the IFR distally from 0.6 to 0.85. But otherwise, there's diffuse disease, and you need to make a decision whether to treat or not. I can't tell you that, but I can certainly tell you that this is the only tool out there which can give you information about serial stenosis and let you make that decision yourself. Now, we're going to test this, and this is one of my last slides here in the defined GPS study. Very interesting study, 3,000 plus patients using this co-registration technique in patients who have positive evidence of ischemia in artery in comparison to an angiographically guided arm. And it's going to be very exciting to look and see the differences between these two arms as we anticipate that more refined patient-specific assessment and treatment that you get with defined GPS. So here's a summary slide. I'm not going to dwell on this very long. It's what I've been speaking about in this talk, but just going to summarize my talk and then give you my parting messages. The clinical data using IFR or FFR is identical in almost all cases. Many cases, however, where IFR is superior to FFR, that's without doubt, it clearly shows it in the data. IFR is the only non-hyperemic pressure ratio with 2 randomized controlled trials and 1A guidelines. Cost is significantly cheaper with IFR than FFR. Now, I'm not a scientist, or sorry, I am a scientist. I'm not going to tell you what to tell you that FFR is dead, but hopefully I've presented the evidence and data showing that IFR and FFR outcomes are identical in many areas. And when not, IFR is usually superior. I think using physiology, and I disagree with the previous speaker, I think using physiology is more important than arguing about which type of physiology to use. And I think it's the most important thing to making good decisions. But personally, I've enjoyed the benefits of IFR co-reg and the significant reduction in symptoms my patient benefit from that, both in the lab and afterwards. And that's where I really found my decision. Thank you very much for the opportunity to speak. I'll hand back to you and the live panel. Thank you.
So before we go to the discussion part, I would like Dr. Neil Johnson for the rebuttal on this lecture.
Well, rebuttal, I mean, the slides have been shown for many years. I think that, again, it comes down to this notion of why you think we do stress testing in cardiology. We do stress testing for everything. And the reason that we do that is that autoregulation largely blunts our ability to understand what's happening under resting conditions. And that the clinical trials, again, as I said, sloppy trials reward the non-inferior endpoint. And I think that once the trial design has been set, it doesn't matter if you follow it for 1 year, 2 year, 5 years or whatever. If you start wrong, there's no way you can kind of recover with excess follow-up. So I'm not sure that we need more follow-up on those particular trials. I think that stress testing remains for me the only way to really understand why these things are happening, because of the body's enormous ability to compensate under resting conditions. It just doesn't make any sense from that viewpoint.
Yeah, so one question to each, and then I'll open up for the rest of the other panelists and experts. Dr. Neil Johnson, so is it true that you don't do IFR at all? And if you do IFR and if it is positive, would you just stop there and not do FFR?
I'm not sure that we don't have a volcano console that has IFR in our hospital. So to answer that aspect of the question, is no, I never use it. But you're asking me, what do I do with resting measurements? And sometimes you have enormous pressure gradients under resting conditions. I can show you some of those cases. Remember, until the coronary pressure gets down below 40, largely the heart is able to compensate for that because of autoregulation. And so under those conditions, if your goal is to try to understand where the pressure loss is happening in the vessel, is this something that's focal or diffuse, and you have a huge 30, 40 millimeter mercury gradient, you're going to be able to do that with resting conditions. I would say that I'm trying to, the vast majority of the time, I do stress measurements on patients, I guess with the rare exception of people who have just enormous gradients under resting conditions that I'm testing for other reasons.
Okay, and to Dr. Justin Davis. So you are so much believer of IFR that have you stopped using FFR at all, or you do it in selective cases? And the other question is, what about Syntax 2 protocol? So after listening to both of you, I mean, many of us would get confused whether to believe this or that. So is it a good compromise to follow the Syntax 2 protocol?
So I would do whatever you want to do in the cath lab. I'm not a zealot, unlike Niels. I would never advocate not to do one technique over another. I do both because I'm a scientist. And I like to explore what the differences are rather than just ruling one out over another. So of course, there are going to be cases when I do FFR, not just in clinical trials, but in clinical practice, because it makes sense. But I remember this must be about 5 years ago, Patrick Sorois wrote a very interesting article in Neurointervention, where there was a lot of discussion and debate by the then Nico Pills, who's not really in the discussion anymore, and myself and Javier Esquinard and a few other people around the world, who were talking about which technique is better. And Patrick said, let's see what happens and see how people vote with their feet, because the people always decide which way they want to go. Now, all I can tell you is around the world, far more measurements are being made with non-hyperemic indices. After the Flair and Sweetheart studies, all the major US large institutions and academic excellence centers switched overnight. And, these aren't fools. And so the reason they're doing that is because it makes sense, and it's good for patients, and it gives them more information they can get otherwise. And so, anything in technology, any technological advance, wherever it is in the world, always carries people who are going to try and cling on to the old ways. I mean, the best example maybe is with PPIs and the gastric surgeons. And I think that, whatever happens, people are going to use PPIs and you're not going to be chopping out ulcers anymore. But there are always going to be some surgeons there saying they should stick with the old way. And, we need to respect them, but also understand that perhaps they have other motives and reasons for doing that over and above those which are kind of purely scientific.
Yeah, and how about this range of 0.86 to 93?
Oh, yes.
Do you think is intermediate?
No, I don't. I think that's completely gone. I think that you have to realize that was at a time when there was a lot of discussion and we're trying to understand the industry, and it was before time we had outcome data. Now you've got outcome trial data, which is essentially around the cut point, and we know from all the data out there, however you look at it, people who have serious adverse events have physiology results which are in 0.65, 0.66. 0.88, 0.89, 0.80, they may get angina, but rarely, if they're well controlled on good medical therapy, do they actually drop dead and have serious events. And Niels has published widely on this. So I think that, there's nothing to stop someone coming back into the cath lab if they have ongoing angina. But as we know from all the studies, Courage, Orbiter, ischemia, just stenting these people is the wrong thing to do. And if it's really near the cut line borderline of either of these indices, you can be very confident and calm and patient with your decision making.
Yeah, so I think all the data has to be interpreted in totality rather than just single, because if it is borderline IFR or FFR, we have to see that the patient fits into the ischemia protocol or the Courage. If he has a distal left main 30-40%, then that possibly was an exclusion criteria along with downstream disease. So, right. Any final comments, Dr. Neil Johnson? Then I throw it open to the to the other panelists and experts.
It's interesting, this comment about science, right? So science isn't vote with your feet kind of thing. That's not the way science works. That's not the way that the scientific method goes. Please bring on the comments from the panel.
Yeah. Other experts and panelists, please.
So if I were Dr. Johnson and Dr. Davis, if I may ask, suppose we have a patient, as Dr. Shah was pointing out, we have a patient who, let's put it two scenarios. One, angiographically doesn't look to be much, has symptoms, so we would want to do an FFR. We do an FFR, the FFR comes negative. Do we go for an IFR? Because we assume the symptoms are because of this lesion. On another scenario, we assume this, we have a lesion which looks another 60%. We're not very happy about stenting it. We do an FFR, it comes positive. So should we again go back to IFR? Should both these methods work together, or there should be just one method one should follow? I think the question is open to both of you, sir, because you guys have to will be able to tell us the best.
Personally, I think it doesn't matter, and I'll tell you why. Because if you look at a study like FAME, because of the variability of any of these indices around the cut point, it means that there are going to be people who have an FFR of 0.78 1 minute and 0.82 the next. Same with IFR as well. So it means the clinical trial, if it had shown there's a clinical, a really dangerous point around 0.8 for FFR, we would have seen some kind of spike around that, but we just don't see it. So this is why I say you've got to be very pragmatic in your decision making. If you're talking about something which is just 1 unit over a cut point or not, you know, you've got to think in the totality of the patient. So it may be if there's an obvious type A lesion that you do want to treat it, but you have to remember that the data shows you that that may not be the right thing to do from a PCI against medical therapy study, but you may want to defer it. And I think that's completely reasonable as well. I don't think it's playing one index off another. I think it's just really understanding that if you're close to the cut point, it's probably going to be a borderline lesion, whichever index you're using. That's how I would interpret the data. And I wouldn't try and compete one thing against another. I think, you know, choose what you want to do and use it. But the worst thing is for an interventionalist to try and chase a PCI, because I think that's a really bad thing where they say, I can't get it with one, I'm going to try another. And if that's still negative, I'll get the IVUS catheter out. And if that's negative, I'll get the OCT catheter out. That's not right. And there's no evidence to show that that approach works. I think that's, you know, pretty clear.
Yeah, Dr. Neil, your comment?
I would say that for FFR negative vessels, you know, I'm not sure that PCI can resolve whatever the mechanism it is for chest pain that's happening in that vessel. Perhaps it's vasospasm, perhaps it's subendocardial stuff, high LV filling pressure, you know, a whole long list of reasons, but whatever it is, sticking stents in that one is not going to help. So I would walk away from it and do other things. And I agree. I think doing tests until you get the answer you hope you want is not something that is useful. I think that you need to at least be consistent with whatever strategy you're using to make decisions. Otherwise, you'll lose confidence in yourself.
Dr. Shah, should we go ahead for the last presentation?
Yeah. So thank you, Dr. Neil Johnson and Dr. Justin Davis. See you once again on some other weekend, at least virtually. Thank you.
Pleasure.
Namaste.
Thanks. Namaste.
Thank you very much. Yeah, so we go on to the last session, and my apologies to Dr. Rajesh for giving him the last opportunity.
That's fine.
But nevertheless, it was a very exciting session. Yeah, so I think this was one of the best, most exciting sessions to listen to both of them on opposite sides. So we come to this last session, and that is a live in box by Dr. Rajesh Vijay. As you all know, he's the organizing secretary for this conference, director at the PGI Chandigarh of Cardiology Department, and very highly accomplished interventional cardiologist, runs a WhatsApp group of PCI images, and has a lot of publications about imaging. Almost every week, we see one of his cases, and revises us about many things in imaging and physiology. Thanks, Dr. Rajesh, to organize this meeting this time. And we had an excellent session so far. So please go ahead with your live inbox case. And I request all the panelists and experts to be there till the end, and please put in your comments.
Thanks, Dr. Shah, for the kind introduction. So let me go ahead. This is the case of the left main bifurcation calcified lesion, which has been taken care by the twist and technique. Okay, so welcome to the Department of Cardiology, PGI, Chandigarh. This lady, 65-year-old hypertensive female, had a CAD, chronic stable angina, and had a bypass surgery for left main bifurcation disease in 2017. Lima to LAD and right internal memory to ramus was implanted in 2017. And recently, she again presented with unstable angina with the ECG, which is showing the ST elevation in AVR. With this presentation, she had an angiography done outside of our institute, where it was found to have a left main bifurcation disease, and both Lima and Rima bypass graft got blocked. And therefore, she was referred to our center for the revascularization. So here is the right coronary artery, which is dominant and normal. Next view. So here is the Lima, which is totally occluded. Rima is also occluded. And this is the left main, which is a bifurcation disease. Next view, Medina 111. You can very well appreciate the LAD left main, which is calcified. Proximal to mid LAD is also calcified. Distally, it's an insignificant disease across the LAD. Next view, it's a calcified left main. Here you can very well appreciate the left main calcified disease. We have taken the 7F EBU guide via the right transfemoral approach. And a microcatheter was placed distally in the distal LAD and exchanged with the rota wire. And this is a rota 1.5 bar. 0.5 bar across the left main to LAD. A good flow across left main to LAD could be achieved after the rotablation. So LAD could open up to certain extent. Next view. And here is the rota wire across the left circumflex. And this is the 1.5 bar across the left circumflex as well. And this is the angiogram after the rotablation of both LAD and LCS at the left main bifurcation point. This is after the rotablation. And here we had an IVUS done across the LAD and also the LCS. So can you show the IVUS for the LAD? So here is the run of the IVUS across the LAD. The size is 4 millimeter. Proximal LAD calcified, though it's not, say, less than 180 degree arc of calcification. Here the calcification has increased. It's around 180 by now. And then now we are moving towards the left main. This is the left main, which is markedly calcified with marked decrease in the area across 360 degree of the calcium across the left main. So this is the IVUS run across the left circumflex. It's ostium at the 4 and proximal part, it's around 3.5. It is again markedly calcified at the ostium. See the area which has markedly decreased at the ostium of the left circumflex. And here we enter into the left main. So this is where we are, 2 BMW wire across both LAD and left circumflex after doing the rotablation with 1.5 bar, and the IVUS imaging, which has shown a markedly calcified left main bifurcation with Medina 111. So let me go ahead and dilate the ostium of both LAD and LCS with a 3 millimeter NC balloon. So area across the left main is 2.9 millimeter square. Go ahead. 18, 20.
So, Dr. Rajesh, just couple of basic questions before you go further. What was the LV function and the GFR of this patient? And did you require any MCS support or anything like that?
So LV function was okay. It's around 60%. EF was fine, and creatinine was also normal. It's 0.8 or 0.9 something.
Exactly. So excellent. So this was good. At least some positive thing about this patient, in spite of a failed CABG and a calcified left main bifurcation.
Absolutely right. This is a very tough lesion and would have required would have required the hemodynamic support in case the LV function would have been on the lower side. But as the EF was absolutely normal, I went ahead without doing the IABP support for this particular patient.
Very good. And there was not much of thrombus despite being unstable angina because...
No. Yes, absolutely right. There was no thrombus and it's all the calcification which is there.
So what's your next strategy after rotablation? Would you like to go straight away with an NC balloon or with a cutting balloon, scoring balloon, IVL balloon? So what is your line of thinking in such cases?
So
cost apart.
Yes, so despite doing the rotablation, if you see there is a significant residual stenosis at the ostium of both LAD and the LCH, so it further requires the plaque modification. We have already seen in the IVUS after doing the rotablation, the area is markedly lower in the side. The area is around 2.9 for the left main, distal left main, and of course it's on the lower side for both the ostial LAD and LCX. So there is further need to have a calcified plaque modification, whether it is by the cutting balloon or IVL balloon.
Yeah, and on the IVUS, we could not see cracks on them despite rotablation. So
yes, absolutely right. We have not done the baseline IVUS to look for whether there is any comparison of having the crack or not. But then, yes, it is markedly calcified at the ostium 360 degree and crack is not very well visualized.
So any panelist would like to comment on this and give his opinion as to how one would go straight away, either with IVL balloon or cutting or scoring balloon, any other device which one would use other than an NC balloon?
I'm Dr. Sudarshan from Lucknow. I have a question to Dr. Rajesh as well as Dr. Shah. Do you think that strategy of IVL over other scoring balloons or NC balloons could be superior in this case? Or you can do a rotatripsy?
No, the question is how to go ahead further. So let's go further before any further comment, or you can very well suggest how to proceed further. So by now I had done the rota across both LAD and HCX, and now going ahead with a 3 mm NC balloon to dilate it further.
Right. So please go ahead, Dr. Rajesh. Let us see what is the result of your strategy.
Fine.
After balloon dilatation, we can again reassess.
With 3 mm NC balloon at 20 atmosphere. Now let's dilate it. 12, 15, 18, 20. Okay, negative. So here we are after balloon dilatation with the 3 mm NC balloon across the left main bifurcation. So let me go ahead and have further modification of the left main plaque with the IVL balloon. So 3.5 into 12 IVL balloon, which I am pushing it across left main to LAD.
Yeah, and is your strategy to use the same balloon to left main to circumflex in case you can save the cycles?
So let's see. Now there is a concern about say trackability when you have an IVL balloon which got dilated across the lesion. So This is the 3.5 millimeter balloon, which I have, I'm going to use across left mid to the LAD. And the same balloon is expected to go across the left circumflex as well.
So let's go ahead. Inflate at 4. Okay, one cycle completed. There is certain fall in the blood pressure. Negative. You start some inotrop, please. So blood pressure is coming up. So let me go ahead for the second cycle. Blood pressure is fine. Negative. So there is a fall in blood pressure following the inflation of this balloon. We have successfully delivered 2 cycles across left main to LAD. 3.5 12, which I could push across hostile LCX without much of the problem. And at 4. Inflate at 4. And here we go. Here we go.
So this is the IVL balloon across the left circumflex as well. I had no difficulty in pushing the same balloon which I did use for the LAD, and therefore I took the another balloon of say 3.5 for the LCX, the newer one. So this is the second balloon which I used for the
You can
LCX.
see the artifact across the ECG panel.
Yes.
Regarding the IVL therapy. Negative, negative. So let's again go ahead at 4. So if patient is poorly tolerating the inflation of the balloon across the
Right, he's very sensitive. We can see the ST segment changes also, as well as the fall in blood pressure.
Absolutely right. So there was a difficulty. The blood pressure was dropping down to 50 and less than 50 whenever I was inflating the balloon across the left main. Whether it's a LAD or the LCX, there was a fall in the blood pressure. So ultimately, I could deliver only 2 cycles to the LAD and also the left circumflex.
But the waste did disappear. That was more important.
Yes, and also the LCX.
Yes. So, Dr. Rajesh, one thing which we learned just now, very important from your demonstration. If you can hold on for a second.
Yes, yes, please.
I would like to comment on this because you see, many a times we find this, that when you take a new balloon through a tortuous lesion, that will go in smoothly. But if the same balloon is used in some other vessel and now you're using the same balloon in the tortuous vessel, the profile of that balloon, especially 3.5, which has got a larger profile, would not go. And exactly that is what happened in your case, and you had to take a second IVL balloon. So here I would suggest that we should first use the fresh balloon, the fresh IVL into the tortuous vessel. And even if that profile goes away, it will go in the straight vessel very easily, just to save on the cost. Otherwise, for a routine balloon, we may not matter 20,000, but in an IVL, definitely 2.5 lakhs would be a big difference in a private practice. Of course, not in your practice maybe, but in private practice, it makes a big difference for us. So I think this is a very good lesson for all of us.
Absolutely right. I had no difficulty in pushing the various devices across the tortuous hostile LCX, which is stent true for the cutting balloon, which is stent true for the IVL balloon. And even to the NC balloon, there was certain difficulty in pushing it. Absolutely right. Instead of going for the LAD, it should have been better for the LCX first to be followed by LAD. But I thought there was some difficulty, and then I just want to preserve the LAD first, followed by the LCX, and therefore went ahead with the LAD, IVL, followed by the LCX. Retrospectively, you are absolutely right. It could have been that LCX first to be followed by LAD for the IVL.
So, Dr. Rajesh, I would tell you, the value of your demonstration live in box today is 2.5 lakhs multiplied by the number of attendees.
So how many $1 million? I don't
know. Okay, let us go ahead now.
Let's go ahead further. So this is what after the IVL.
Kissing balloon inflation with 3 and 3.5, 2 balloon across left circumflex and LAD respectively.
So
So
here,
without the difficulty, I am able to push both the balloon across the left main bifurcation, and let me inflate it. 14, 15, 18, 20. So it's a 20 atmosphere negative. So here we are after the balloon dilatation across both, and we could dilate it very well. So finally we are able to dilate it both LAD and LCX after say 1.5 rota, IVL, and then the NC balloon. Let me go ahead and put a cutting balloon as well across the left circumflex and also the LAD. So this is the cutting balloon across left main to LAD. Just inflate it, inflate it. It's a 3.5, 10, 12, 18, 20. So we have inflated negative, negative. The cutting balloon across left main to LAD. Yeah.
Right. So another good thing which your demonstration is that you are not worried about the side branch wire when using a cutting balloon for that, right?
Absolutely, absolutely right. Using the cutting balloon, there is no need to remove the side branch wire. And personally, I feel like there is no problem in any of my case where I use the cutting balloon.
Right. So let's go ahead now. Let's see the result.
It's 18 atmosphere negative. It's better now across ostium of the LAD.
Yeah, there it appears good, but the ostium of the circumflex, maybe there is a lot of recoil.
No, other than recoil, there was a problem in again pushing the cutting balloon across the LCX,
yeah.
and therefore I had to take it another newer balloon for the LCX as well. So this is again a new balloon for the left circumflex.
So we could ultimately dilate both LAD and also the LCX with the cutting balloon. That's a 3.5 millimeter. Very nice. This is what the result is across.
Yeah, so this time it appears better.
Yes, it's a better, but still there is some residual stenosis across ostium of the left circumflex, though the LAD is fine.
LCA, which is how much? 4 ostium, and LAD is again. So let me give. It's a 3.5, 15 synergy. So it's a 3.5 stent across the LCX ostium. So stent got well expanded across the ostium, dilated. 12, 13, negative. This is the result across the LCX. Let me post dilated. Ostium is how much? 4. So give me the 4 millimeter balloon. 12, 14. So we are dilated negative. We are dilated it with a 4 millimeter balloon. Inflated. 12, 14. Negative. So let me cross the LCX negative. Epicaudal. So this is what we are there with the LCX. Inflate. Balloon inflate. 14, 18. Negative. So this is a 3.5. This is a 3.5 millimeter balloon across the LAD to cross the LCX stent. And let's go ahead for left main to LAD stenting. So we do an LAD which is 4 millimeter. Let me go ahead and put a 4 millimeter stent across. I think this is okay. Test it. I think this is fine. So this is left main to LAD. Let me pull it somewhat more to cover the ostium. Here we are. 12, 14, negative, 14, negative. So give me a 5 millimeter balloon for the port of the left main. So here we are with the 5 millimeter balloon for the port. Let me see where we are. Test, please. So we are okay. Let's inflate it. Let's inflate it. Let's inflate it. 8, 10, 12, negative. Negative. So we have done the port with the 5 millimeter balloon across the left main, and this is what the result is. So this is the result across the left main. Bifurcation, very much satisfactory. Let me do the final kissing followed by port and then the final IVUS wire across. Having the difficulty in crossing the balloon, so let me take another newer balloon, 1.5 or 2. Regarding the crossing of the wire across, I'm not sure whether it's
Proximal or mid?
Proximal, seems to be somewhat proximal. So it's a 1.5 10 millimeter balloon, which I'm pushing. How much? 15. So could cross it. Let's inflate. 15, 18. Could dilate it. What's the length? 1.5, 15. Okay, okay. Go ahead, go ahead, go ahead. 2.5 millimeter balloon. So here is the balloon. 2.5 across, inflate. 18, 18. Negative. It's a 2.5, and let's have the final kissing across the two stent. So LAD is 4, LCX is 4. Let me take two balloon of 4 each for the LAD and LCX, please. 4 and 4. So here we are. Stent boost, stent boost. So LAD inflate. 1, 8, 18. Negative. So we have inflated the balloon across the LAD at 18. Now it's LCX, 1 at 18. 18. Negative. And both inflate at 12 atmosphere. So this is the final kissing, negative. This is the result after kissing balloon, very satisfactory. And let me go ahead and do the port with a 5. Negative. So this is the port with the 5. Let me pull back somewhat and then go ahead 4. So go ahead. 14, negative. So port with the 5. This is what the LAD and LCX spider view. This is the end result across the left main bifurcation. Let's have the final IVUS. There is some fall in the blood pressure following the NTG, so let me hike up the dosage of inotrop. So here we are across the proximal LCX. So ostium of the L6 is fine, not able to push the catheter distally. Here we are at the ostium, and now it's a left main basically. It's a good result. .15, okay. So area across the ostium of the L6 is satisfactory. And now it's a catheter across the LAD, calcified non-stented mid-LAD segment. with 360 arc of calcification. So stent got started. It's a 4 millimeter stent, well opposed and expanded stent across the left main to LAD. Markedly calcified. This is the left main, and then we are out. What's the area across the left main? 13.26. So that's something very satisfactory. So LAD ostium is 9 millimeter. Thanks for being with us.
No, thank you very much, Dr. Rajesh. That was excellent demonstration of not only calcified left main bifurcation, decay crush, and of course the final pictures, both angiographically and the IVUS measurements did show excellent results, more than what actually the Nordic trial for the left main IVUS criteria had shown. So this is more than that, and I think the patient will definitely benefit from all this. The long-term results will be excellent. Now, from the other panelists, your comments or questions from the other panelists, please.
Sir, if I may, beautiful result at the end. It is something we couldn't imagine. But just two questions with your experience. How would it have been better if you could have upgraded the rotablator? Maybe could have saved the IVL. And second question, how, in your experience, how good are cutting balloons in severe calcified lesions? Are they helpful in debulking the entire thing, unlike rota, which you can upgrade to a 1.75 or a 2 also, and maybe debulk the lesion for plaque modification?
So very good question regarding the sizing, say 1.5 to say 1.75 or 2. If you see the size of vessel, the left main is 5, ostial LAD and proximal is 4, and then the proximal L6 is 3.5. So despite increasing the size of the rotabar to say 1.75 or 2, you are not going to achieve much of the area. And the principle of rotablation is just to have the pulverizing the thing and not to have a good area across. The main principle to have the rota is that you are able to pass the various devices across without much of the difficulty. And therefore, we could have an adequate passage to pass various devices after having the rota ablation with 1.5. And of course, the compliance of the lesion also do improve with the rota ablation. So both the thing could be achieved after doing the rota ablation across the left main to left main bifurcation, having both the LAD and the LCX. Thereafter, as we had the dilatation with the NC balloon 3 millimeter across both, and we couldn't have a good dilatation of the left main bifurcation, there was a need to have further plaque modification, which only can be achieved by the IVL and the cutting balloon. Here, as the calcification was too much, I thought let's have the softening of the calcified plaque with the IVL therapy instead of say cutting it with a cutting balloon, which is not going to soften the lesion. And therefore, we went ahead and put the IVL balloon across both the lesion. But the limitation of the IVL balloon in the index case was that I couldn't go ahead with a good amount of therapy. It's only the 2 cycle instead of say 8 cycle, which I have further modified the plaque to great extent. And therefore, I have to add the cutting balloon further to have a good plaque modification before going ahead for the stenting. And therefore, later on, I had to subject the patient for the say cutting balloon as well. What I have observed after using the rota ablation, it's the cutting balloon which gives the good area across. So in my practice, it's very frequent to have the rota followed by cutting balloon instead of say rota with NC balloon to have the appropriate plaque modification before going out for the stenting.
Yeah, so can I give some comments on that?
Yes, please. Yes,
yeah.
please.
So in the ideal world scenario, what we saw just now is the ideal world. I fully agree. But you see, just imagine IVL is introduced just a year or two back, right? What was the scenario before that? And even today, IVL is not available in many countries. Even US got its FDA approval just a month back or 2 months back, right? So what were they doing before that? Not that they were not doing calcified lesions, we were all doing it. Okay, so you are right in a way that if you want to keep your IVL only as a bailout strategy when things are not working before stenting, I'm not saying after stenting, then right, go ahead. Once the idea of putting a 1.5 and rotablating is to get an imaging catheter down and see what it is. As we all heard from previous sessions, the most dreaded thing which we don't want is to have a calcified nodule with a normal wall on the opposite side. If you have a calcific nodule with 360-degree arc of calcium, then we are less worried. You can still use cutting balloon or the rotablation again with a wire bias, no problem. Okay. But if you have a calcific nodule on one wall and a normal 180 degrees other side, then you are worried even to use a cutting balloon because you may perforate the opposite side. So these are the two caveats which we don't want. So when we heard this calcified nodule, I would divide calcified nodule into two. One with arc of calcium, 360 degree, and one without. The one without is more worrisome to me. And unless there is a bias, a wire bias, a rotablator to use in that situation also is not good, or a cutting balloon also is not good. So there, at the most, at present, we can use an IVL, which may soften the nodule and give without doing any damage to the normal arterial wall. So I think we have to be judicious and use these devices. As he rightly said, that he was not very happy that the amount of pulses which you could deliver were not much, and therefore he used a cutting balloon after that. But if your pulses are adequate and you have got good expansion, then NC balloon is fine. Even NC balloon 1:1 size is good enough to give the expansion and get out the waste and then get a good stent result. So I think strategies, and don't forget OPN balloon also. You see, under expansion, see, if you have, as I said, 360-degree arc of calcium, even if you have, and if it is less than 5 millimeter, 1 or 2 millimeter, that also is how much? According to calcium score, it will be 1. Right? Only if the depth is more than, the length is more than 5 millimeter, then it goes above. But otherwise, it would still be amenable, I would say, for cutting balloon or scoring balloon, especially cutting balloon. If not, even high pressure OPN balloons also can be used in such cases. And after stenting, of course, if you still feel it is under expandable, you can use OPN balloon for that also. Excellent.
So Dr. Saib, any concluding remark for this particular session, and let's close it then?
Yeah, it's 11 o'clock. I think, no, I think it was excellent session. I mean, first of all, I should congratulate you and the whole IPCI team for keeping this debate. I had heard this debate about 2 years back. I think it was in Chennai. Vijay Kumar and Dr. Ajit Mulasari had organized. Vijay, was it 2 years back or 3 years back?
No, 2 years back.
2 years back, right. And I think physically Dr. Davis was also there that time. Right. But it was nice to hear them once again with some fresh data and fresh thing. Overall, today I attended the whole program. It was excellent, and the way it went. And of course, the last case was just one more practical teaching, step by step, how things should be done in a calcified lesion. And IVL makes it more predictable. You see, less complication and more predictable. So that what it brings value to that. So thank you, Dr. Rajesh, Dr. Vijay Kumar, and the whole team of IPCI for today's session. Thank you.
Thank you. Thank you.
Thank you very much. And let me conclude today's session. So as we now head to the conclusion of the day one, I must admit that it was a remarkable day for all of us. On the behalf of organizing committee, I would like to thank each and every one of you who spared their precious time to attend this meaningful event and enlighten one another by sharing their respective experience in different geography and subset. A big applause to all the respected speakers, chairperson, and expert panelists to make the first day even more interactive and interesting despite being connected virtually only. Today, the total participant in the meeting was around 350, which includes around 50 faculty members across the globe. So let's get together again tomorrow morning to have an experience of another wonderful day full of knowledge, sharing, and also learning from each and everyone's experience. We do have a fellow course tomorrow morning at around 12 noon, and then I request you all to ask your fellows to kindly join the session. It's going to be basic and informative about the imaging and also the FFR and functional assessment of the coronary lesion. Tomorrow evening, the session is going to start by say 5:30 instead of the 6. And I again request you all to be there with us to make the event more successful. And good night to everyone.
Good night. Take care. Stay safe.
Thank you, sir. Good night.